I think some people will cling to the paucity of mortality data or the lack of huge positive RCTs in the ICU or in critical care medicine, use that as a reason for not doing X. Often behind a frown, some deeply bagged, dark eyes, heavily stained coffee cup. Others, and hopefully I fall into this camp, will instead just recognize that doing things for the sake of doing things is maybe not always the best option. It often begets complications with little benefit. And frankly, many of our patients will get better with time and just kind of good general critical care. I often will say semi-jokingly and semi-not, do as much nothing as possible and just watch your patient carefully and be ready to act when acting is necessary. Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your co-host, Dr. Cyrus Asking. Here, as always, is my co-host, the good Dr. Nick Mark. Nick, how are you doing?
Better now. So we were recently struck by a bomb cyclone here in the Pacific Northwest, which took several of those beautiful Pacific Northwest trees and dropped them on houses, cars, roads, and power lines. So for me, that meant no power and no internet for almost a week, which kind of threw a wrench into some of our plans, including our plan to record this episode.
Yes. This one has been quite a while in the making, but hey, at least you survived.
That's right. And it was kind of great to disconnect. I missed recording, but it was nice to just chill with a book in front of the fireplace for a few days.
That does sound nice. So now that you've run out of excuses, what are we actually going to talk about today?
I'm glad you asked. So today we're going to talk about a topic that's near and dear to both our hearts, cardiogenic shock.
Oh, how clever of you. Well, this will be, I think our fourth try to record this episode. So hopefully we'll actually be able to get this done and share it with our beloved audience.
It is Friday the 13th, so what could possibly go wrong? All right, so literally in our first episode of Critical Care Time, we introduced the concept of shock and undifferentiated shock. We also introduced this idea of how it's useful to break shock into categories, like talking about the pump, the tank, or the pipes, with corresponding to like cardiogenic obstructive, hypovolemic, and distributive shock. Today, we're going to double click on pump problems, specifically on cardiogenic shock in general terms, and we'll talk about the RV and the LV. It's going to be great.
Yeah, so this is really going to be an introductory episode to a very complex topic. And while we're excited to get to the nitty-gritty, we're equally excited to start the dialogue. So if you guys have been listening along with us, we've already covered some of the major causes of obstructive shock in our prior discussions on pulmonary embolism and pneumothorax. So we felt it was time to move on to this fairly important and high-yield critical care topic. It's also important to know, or to remember, I should say, that these shock states, they don't exist in vacuums. They can often coexist. So just because someone comes in septic shock, it doesn't mean that their septic shock won't be complicated by cardiogenic shock. So just because you, don't work in a fancy cardiac ICU like the good Dr. Mark doesn't mean that it isn't relevant.
No, and in fact, it's actually more relevant if you don't work in a fancy cardiac ICU where people are selected because they're coming to this quaternary center for cardiogenic shock. I spend about half my time in the cardiac ICU, but sometimes the most important cardiogenic shock diagnoses that I make are in other ICUs, like medical ICUs, where it's hiding. Like you were saying, Cyrus, this is an intro to cardiogenic shock episode. We're going to try to provide a broad, practical, clinically relevant foundation that will inform care at the bedside. In future episodes, we're going to dive deeper on many of the topics we touch on today, like mechanical circulatory support, things like balloon pumps, Impellas, LVADs, and ECMO. Now that we've done all this stage setting, Cyrus, do you want to explain in more granular terms why it is that cardiogenic shock is so relevant to us and our listeners?
Yeah, absolutely. So, cardiogenic shock is not a clinical burden shouldered by cardiologists alone. We kind of talked about that just here a second ago. Intensivists, hospitalists, and all the clinically important staff members we work with, RNs, RTs, PTs, OTs, PharmDs, and more, all of these folks are going to see patients, right? And all of these patients are suffering from or at risk of developing cardiac problems that could then develop into cardiogenic shock. And so not only is this due to emerging models for coronary care units and cardiac ICUs where cardiologists are co-managing or they're consulting on patients where the intensivist team is primary, but also, again, we've kind of discussed this a little bit, but cardiogenic shock is not unique to CCUs. any of the ICUs that you might work in are places where a patient could manifest cardiogenic shock. So it could be at risk for it, succumb to it, what have you. Okay. And so, we're going to post some of this data on the website, but there's good data from a number of sources. So there's one study we're going to post data from 2019 study showing that there are some pretty important cardiogenic shock trends out there. And fortunately, good news for us. Fewer and fewer people are dying from cardiogenic shock. There was a drop first noted in the 1980s, and that's probably related to an emphasis on revascularization and maybe related to mechanical circulatory support as well, becoming more prevalent. So that's great. Then there's a big drop that's noted more recently, and we suspect that's related to the development of what are called shock teams and better protocols that have been utilized to manage cardiogenic shock. Incorporating mechanical circulatory support in those teams or in those protocols, yes, but really it's the idea of getting teams on the same page in sort of this protocolized and comprehensive and coordinated manner to make sure that these folks are taken care of well. And this kind of approach to care was championed by the NCSI, or the National Cardiogenic Shock Initiative.
Yeah, and I think it's worth emphasizing too that new technologies definitely play a role, right? I mean, the development of percutaneous coronary interventions was a big step. The development of various mechanical support devices and new medical therapies, very important. But I think the teamwork aspect is also really important. The fact that we now have a more multidisciplinary team approach. At my institution, we have a cardiogenic shock team that we activate, just like we do as a PE response team or a STEMI team. And the idea here is bringing all the people together who have the skills to, do the medical therapies and do the interventional therapies that this person might need. And I think that one of the things that we're seeing in the data nationally is that the emergence of technologies and the multidisciplinary teams to wield them is really responsible for a pretty impressive drop in mortality from cardiogenic shock, even in just the last decade.
That's exactly right. Yeah, it's the toys are great and the protocols are great, but you really need the people and you need the teams. It needs to be implemented correctly. And so, I talked about that study from the from 2018, 2019 actually. There's another study a little more recently, 2021, that shows that same sort of trend. So that looked at actually 15 years of cardiogenic shock management. And again, like you see a little bit of a drop that's related to revascularization and the implementation of mechanical circulatory support, but then a much bigger drop in the setting of, again, using those shock teams and implementing those protocols and all of that. So I think definitely the people are really the greatest and most powerful resource here.
I want to emphasize one other point too, which is that it's easy to point to the development of a new gizmo and credit that. And I think the teams are really important, no doubt. But I think another thing that's really been changing is more awareness. I think that we do a much better job of recognizing cardiogenic shock and acting promptly. We view this as an emergency, right? That mentality of like a STEMI is an emergency, a stroke is an emergency. Cardiogenic shock is an emergency. And I think that recognizing it and acting promptly is really something else which is changing.
Absolutely. Yeah. I think that's really important. Like that recognition and early recognition being key. And kind of one other thing I wanted to mention is that we're talking about cardiogenic shock with very, in very broad strokes, but kind of two very general flavors would be cardiogenic shock related to acute myocardial infarction and cardiogenic shock related to things that are not acute myocardial infarction. And these trends that I'm alluding to are seen in both cases. And so it's not just folks that are, suffering from a STEMI. It's really all comers, which is great. So
that's a really great point. We can't give PCI too much credit here. Right. It's really other things too.
Right, exactly. And so, really in summary, I'll say we're doing better for some concrete reasons, but, I think in large part it's due to the people.
But we can do better still.
Exactly. Despite this relatively positive trend, cardiogenic shock is still considered a highly fatal condition with mortality rates that, depending on where you look, are generally spanning from 35 to 50%. And so, I would say that it's still a relatively relevant problem and probably something we should be familiar with.
Absolutely. And that's part of why we're doing this episode, right? I mean, increase awareness, talk about the importance of multidisciplinary approaches and all of the cool interventions that we have.
For sure, for sure. So I think I think we've done a pretty good job of introducing the topic, and so I think maybe we could talk a little about the definition. How do we define cardiogenic shock? I guess. Oh, I don't know. Perhaps we could say the definition of cardiogenic shock is shock due to a primary cardiac cause. How about that?
Perfect. That's a great definition. Thank you. Thank you, NCSI, for that.
Yes, absolutely. Great definition. And I guess it would also be wrong, right? So the reality is, so the definition of cardiac, I should say of cardiogenic shock, it's actually pretty complicated, and depending on how far you want to go down the rabbit hole, it gets more complicated still. So I did quite a bit of digging in preparation for this, and Nick, I know you did the same. I think that probably the most elegant definition I came up with was from a 2020 review article from Tehrani and colleagues, whereby they defined cardiogenic shock as a hemodynamically complex syndrome characterized by a low cardiac output that often culminates in multi-organ system failure and death.
Now we're cooking with gas. That's a much better definition. That makes sense. It captures the sort of complexity, the gravity of it. One thing that we often talk about, especially in this show, is that all shock states are really failures of oxygen delivery, right? And so it could be because you don't have enough blood pressure to perfuse your organs. It could be because you don't have enough blood to perfuse your organs. It could be because you don't have enough oxygen to get to your organs. Or in this case, it could be because you're not pumping that blood to get to your organs. I think that's a nice kind of simple way to frame it, but as you said, it's complex, and we can phenotype cardiogenic shock a couple different ways. We can think about it in terms of severity, which we'll do in a second, but we can also sort of base it on, like, what does this person look like? And so classically, there's this sort of like 2x2 schema that we use. We can think about shock as being warm and dry. That's like vasodilatory shock. That's usually not cardiogenic. It could be warm and wet, which is sort of mixed cardiogenic shock. They often have a low cardiac index, normal SVR, volume overloaded. Cold and dry, or euvolemic cardiogenic shock. This is sort of like a low cardiac index, normal SVR, euvolemic state. And then there's sort of the classic cardiogenic shock, or cold and wet. This is where they have a low cardiac index, a high SVR, they're pumping against a lot of resistance, and they are also volume overloaded.
Yeah, so those are kind of your classic, I would say, clinico-hemodynamic profiles, which I think are a really great starting point. And I think if you're going to commit something to memory to use at the bedside, that's super helpful. However, for something maybe a bit more granular, I think we would recommend being familiar with the SCAI, or the Society for Cardiovascular Angiography and Interventions, descriptors of shock. And so their schema for cardiogenic shock stratifies presentations in a way that clearly expresses really how sick a patient is, and perhaps also their risk for mortality. From a historical perspective, this is largely derived from definitions that were used in a number of pivotal cardiogenic shock studies from really the last 20 years or so, specifically studies like the SHOCK trial from 1999, the IABP SHOCK 2 study from 2012, IMPRESS from 2017, and then the culprit shock study also from 2017.
I'm just going to say parenthetically that there are a lot of RCTs in the cardiac literature, and they all have amazing names. These are all like 4 or 5 star study names.
Yes, and we're gonna talk about a lot of those, or I say a lot, but really probably just scratch the surface on some of those. They're RCTing the crap out of their field, like research is going out of style. But anyway, Nick, do you want to introduce their approach to stratifying cardiogenic shock for our audience?
Absolutely. So the SCAI stages go alphabetically from A to E. It starts with A, which is considered at risk, and they end with stage E, or extremis. Between you have stages B, C, and D, which stand for beginning cardiogenic shock, stage B, classic cardiogenic shock, stage C, and deteriorating/doom, stage D. Sort of going through those one at a time. So at risk, or stage A, is a patient who really isn't in shock, but they have a substrate for it. They're at risk for it. This could be somebody with like a large acute MI. This could be somebody with bad underlying chronic heart failure who comes in with a decompensation, who could, quote, fall off a cliff. On exam, these patients typically look warm and well perfused. They might have an increased JVP. They might not. They should have normal organ function. So they may have normal mentation, good pulses, their renal function should be okay, their liver function should be okay, their lactate should be okay. Hemodynamically, if we were to get numbers, the numbers would be above our thresholds, meaning that their index, their cardiac index is greater than 2.5, their CVP is probably less than 10, their PA sats are over 65. But maybe before we even go to stage B, beginning, maybe Cyrus, we should take a minute to kind of review what some of these numbers mean.
Absolutely. I think it's a great time for a little reminder, refresher. How about I go through the basics and you remind us how we can obtain the data?
Sounds great.
Okay. Recall that cardiac output is one of the primary measurements we consider when discussing cardiac function. That is classically the product of heart rate and stroke volume. A normal cardiac output is anywhere between 4 to 8 or so liters per minute at rest. However, in an effort to normalize that, we can actually view cardiac output relative to a person's body surface area. And derive what's called a cardiac index or a CI. And that's typically going to be 2.5 to 4 liters per minute over meters squared.
And I would strongly encourage our listeners to banish cardiac output from their mind and think in terms of cardiac index whenever possible. People vary in size a lot, especially in America. And you need to consider size when you're evaluating somebody's cardiac output. So let's just take, for example, somebody has if we want to have a cardiac index of 2.5 and above, right? Just think about like two example patients here. So 5 liters per minute of cardiac output would be a cardiac index of 1.9 in a 6'4", 120 kilogram bodybuilder. But 5 liters per minute of cardiac output would be a cardiac index of 4.1 in a little tiny 4'8", 40 kilogram grandmother. So depending on the patient, 5 liters per minute could either be critically low or too high. You need to consider how big this person is. So CO doesn't convey enough information. Banish it from your mind in your ICU. I only want people to report cardiac index.
That's a really good point, Nick. And something I think our listeners definitely should remember. Now, another important measurement that we're going to talk about, and we're going to sort of later on discuss how we can actually get this data specifically. But another important measurement we're going to talk about is the CVP, or the central venous pressure. Now, as a brief aside, this isn't the kind of like CVP be all and end all, use this to determine how you manage sepsis CVP. This is kind of, it's the same measurement, it's the central venous pressure, but we're talking about it in a very different context. We're talking about it in terms of like how we view someone in cardiogenic shock, not as a like, I'm going to give this person volume or I'm not going to give this person volume sort of thing.
Right.
So
I think a lot of people have overgeneralized the idea that like CVP was used inappropriately in sepsis as a marker of volume responsiveness to this weird general concept that CVP is never useful. And especially in the patients we're going to talk about today, CVP is an important number in assessing RV filling pressures and function, particularly in people with heart failure. So, don't be a CVP nihilist. It still has uses. Just
That's
not
exactly
those
right.
bad uses.
That's exactly right. Yeah. So really it's the CVP, central venous pressure. It's really just a surrogate for right atrial pressure. And thus it's an indirect and an imperfect tool, albeit, but it's an indirect measurement that we can use for sort of volume status, quote unquote, how congested perhaps a patient is. And in advanced left-sided heart disease, when a patient is volume overloaded, this number is often high. It can also be high in volume overloaded patients who have isolated RV failure. It can also be high in volume overloaded patients for other reasons. So again, that's why it's kind of like not the be all and end all. It's not perfect. There are definitely challenges with the CVP.
Never hang your hat on just one number, right? We should evaluate many different things. That said, if you want to evaluate one number, what is an SVO2 and why do we like that number, Cyrus?
Yeah. So, the PA sat quite literally is the saturation of blood prior to oxygenation in the lungs. The idea here is that in states where cardiac output is low, especially if oxygen extraction is high, the resulting saturation of blood that returns to the PA awaiting reoxygenation is very low. So we expect the SAT to be 70 to 75%, but we accept a saturation of greater than 65% as being normal. For nomenclature purposes, this is also called the SVO2, as you said, or the mixed venous saturation. So that's really what the SVO2 is. It's that saturation of blood right before it hits the lungs. And the idea there is, if it's really, really low, that maybe there's something going on in terms of cardiac function, and maybe that's an indication that things are not all hunky dory.
Right, exactly. So now that we've talked about some of those terms that we use to quantify the severity of shock or the type of shock, let's go back to talking about the stages again.
Great. So, Nick, you've introduced the stages with stage A, or at risk. What's going to come next?
So after A comes B. So stage B, or beginning cardiogenic shock.
Imagine that.
Yeah, crazy. So to simplify things, this looks a lot like your stage A patients, but with a few important differences. This is somebody whose hemodynamics have started to get worse, right? They may be tachycardic, they may be hypotensive. Hypotension defined as a MAP less than 60, a systolic less than 90, or a 30 millimeter of mercury drop from baseline. And I think we often miss that last definition of shock, or drop in blood pressure. If somebody is always hypertensive and poorly controlled, their blood pressure is always, 150s, 160s, you go back through their records, and now they're, sitting in front of you with blood pressure of 100, that may well be shock. So don't fixate so much on just a threshold number. Also put it in the context of the patient. We may also see things like labs are starting to be abnormal. They may have increased LFTs, increased lactate. There may be other things on physical exam like RALs when you auscultate, increased JVP when you look at their neck. In a nutshell, these are folks with clinical evidence of shock with relative hypotension, tachycardia. They're maybe not hypoperfused yet. They may not have that organ hypoperfusion effect yet, but they're well on their way there.
Excellent. Yeah. And I definitely want to kind of foot stomp what you were saying there. I like how they approach this because they don't use those hard BP cutoffs. The greater than 30 millimeters of mercury drop does allow for that possibility of cryptic shock that you're alluding to, i.e. that patient who looks normotensive in the EMR, but actually it's a relative hypotension when you realize that all of their BP meds are held and their blood pressure is 105 over 67 or something like that. So that's a great point.
Great point. Okay, so moving on. So always put the values into context. The next group, classic or stage C cardiogenic shock. These are the folks that we typically recognize as being in shock. They have, clear evidence of hypoperfusion, like oliguria, anuria. They're altered. Their capillary refill it looks bad. They may be ashen, mottled, or cold and clammy. And they often are on medications for these things. So somebody who's on inotropes, on pressors, they fall into this category as well. I think these are the ones that we tend to recognize, though the danger here is misattribution, right? You may think that somebody is in septic shock when they are, in fact, in cardiogenic shock. And that's why it's important to think about all of these parameters when assessing them. Maybe we should talk about the advanced hemodynamic numbers in these folks.
So, Nick, in these folks, in these kind of stage C patients, we typically would expect to see a cardiac index of around 2.2 or less. And then we're going to start looking at some other measurements, as you sort of alluded to. And those are going to include things like a pulmonary capillary wedge pressure, right atrial pressure, and then some calculated values like a PAPi and a CPO. So first getting into that, the pulmonary capillary wedge pressure, this also known as the PCWP, the wedge pressure, the occlusion pressure. Essentially, that's a surrogate for the left atrial pressure or the left ventricular pressure, kind of depending on what's going on. Or the left ventricular end diastolic pressure is another way to look at that. So the idea here is that as the left ventricle is experiencing progressive failure, that pulmonary capillary wedge pressure should rise. Makes pretty good sense. Now, this is assuming there's no progressive aortic valve disease or something else that's kind of muddying the waters. But typically, you would expect your pulmonary capillary wedge pressure to be somewhere in the neighborhood of maybe 10. So 6 to 12 is kind of normal. 12 is even maybe a little generous. A value greater than 15 is when we start to get worried. So we even afford our patients a little bit more of a buffer. Now, the next value we're going to talk about is the right atrial pressure. So the right atrial pressure typically is going to range from 2 to 8. Elevated right atrial pressures may indicate right-sided heart failure. Of course, again, there can be confounders here. So something like a tricuspid disease tricuspid regurgitation as that gets worse and worse, independent of, let's say, right ventricular disease. That could cause an elevated right atrial pressure. But sometimes you're going to see tricuspid valve failure in the setting of right ventricular disease. And so just recognize that we can't really look at this stuff in a vacuum. So in general, though, in the context of right ventricular failure, we expect to see that right atrial pressure rise and rise and rise. Now, some folks will look at the right atrial pressure relative to that pulmonary capillary wedge pressure as another diagnostic criterion when assessing cardiogenic shock. And really here, all you're doing is you're looking at that RA relative to that PCWP. And so if the RA, for example, is markedly elevated relative to the PCWP or vice versa, that may indicate which side of the heart is failing more so than the other.
And the idea here is just that, if the left side fails, it will back up into the right side. So it can help you sort of try to figure out which is the leading problem. Two other tools that we can use to do this are calculations. One is the pulmonary artery pulsatility index, or PAPi, and the other is the cardiac power output, or CPO. These are really helpful hemodynamic calculations that can help us in figuring out where the problem is, left or right. So CPO, cardiac power output, is a direct correlate of end organ perfusion because it's really measuring how much the LV is pumping. If you took any physics, hydraulics in college, you might remember that power equals flow times pressure. In this case, the cardiac power measured in watts is the product of the mean arterial pressure times the cardiac output. And just because we have to make the units work, we have to divide by a number. So the actual formula is CPO equals MAP times CO divided by 451. As CPO falls, it's associated with worse outcomes. And the threshold number to remember here is 0.6 watts. A CPO of less than 0.6 would be consistent with stage C heart failure, and it indicates LV failure specifically. Turning our attention now to the other ventricle, the people's ventricle, the right ventricle, we have this tool called PAPi. PAPi is the pulmonary artery pulsatility index. It's defined as the PA systolic pressure minus the PA diastolic pressure, and all of that divided by the right atrial pressure. And the threshold value here is that as PAPi falls, it tells us the RV is doing less well, and a value of less than 0.9 suggests that this RV is failing enough that it may require mechanical circulatory support. So just to summarize, we've got two calculated values here, the CPO, which tells us about the left ventricle, the PAPi, which tells us about the right ventricle. For both of them, low values are bad. Remember a threshold of 0.6 watts for CPO and 0.9 for PAPi.
That's awesome. Yeah, very good. Very good. And so, the CPO and the PAPi, they're really great tools that we can use in our sicker cardiogenic shock patients when you have a PA catheter in place. For one thing, the two can be used in tandem to get a feel for relative contributions to the clinical picture.
Is this an LV problem, an RV problem, or both? Yep.
Exactly right. Is this more LV? Is this more RV? And so then you can also follow them too when you're making interventions. So, do you have a favorite way to calculate them, Nick, by the way?
So oddly, despite them being really useful, they're not in a lot of these online, easy to use calculators. And I don't know about you, man, but I don't like dividing by 451 in my head in the middle of the night. So I actually built an online calculator for us and our listeners.
Nice.
If they go to the show notes for this episode, they can just plug in their values and calculate a CPO and a PAPi to their heart's content.
Oh, beautiful. That's going to be a super cool option for our folks if they have all those PA catheter numbers.
But what if they don't have all those numbers?
Yes, excellent. So, and I've seen this a lot as a fellow, and now as a kind of a junior junior attending. Point of care echocardiography has really largely supplanted pulmonary catheters for many of us, and so the benefits you can actually see with your own two eyes, ventricular function and that intraventricular dependence, and that kind of those the two ventricles as they interact with one another, which I think there's a benefit to that. Without the technical burden of putting in a pulmonary artery catheter and the potential risks of that, and et cetera, et cetera. But there's a challenge here too, right? So you need to have those good windows. You have the technical skill. I mean, we talk a lot a lot about the technical skill of putting in a PA catheter, and we almost poo-poo how difficult it is to do good echocardiography. It's hard to sometimes get good windows. You have to have those technical skills and you have to practice them. It's not just a matter of like dropping the probe on someone's chest and getting good windows. You have to work for it.
And even if they have amazing windows, someone has to go and do it, right?
Correct.
As opposed to, getting these values that are refreshing every 30 seconds on your swan, you have to go do it. And so I completely agree that point of care ultrasound is incredibly useful. It's the future. If you can get good windows, they can give you a lot of the same information about the LV outflow tract VTI or the TAPC as measures of LV and RV function. You can titrate your inotropes or other therapies based on these. But unfortunately, you may not be able to get them on everybody. In really sick patients who are intubated, it can be pretty hard to get them. And even in patients where it's easy to get them, you have to go get them. You have to drop what you're doing, go back in the room, gown up again. And so that can be a significant barrier to getting really granular data to guide therapies. One thing that we've talked about before on the show is sometimes TEE can be your friend.
That's very true. That's very, very true. It sounds like we're very much on the same page. Big fans of that very important tool. It's not without its limitations. As far as TEE or transesophageal echocardiography goes, it's very promising, but there are, of course, some institutional and technical barriers for many of us there. If you're interested in learning more, you should definitely check out our episode with Ross Prager from season 1, where we talked about that. But anyway, so now that we've talked about POCUS, we've discussed some of the measurements there that you can use. Again, that LVOT VTI to assess LV function, that TAPC is one of the ones that you can use. Also, you can do kind of your S prime measurement to measure right-sided function, among others. Maybe we could talk a little bit about those PACs and the fancy alternatives that exist out there. And, Nick, how do they play a role in your approach to cardiogenic shock? How do you choose from them? What's your overall feeling on that?
Yeah. So, fortunately, there are a lot of tools to choose from. Unfortunately, there are a lot of tools to choose from. So, each one kind of has a time and a place. And we could have a whole episode talking just about, all the different ways of measuring cardiac parameters, invasively with swans, semi-invasively with some of these other tools like Hemisphere, Vigileo, et cetera, and then non-invasively with like a point of care ultrasound. I think, just to give our listeners some context to understand this, the non-invasive tools, the way they work is they do something called pulse wave or pulse contour analysis. Basically, they hook up to an art line and they're doing some complex mathematical analysis of the contour, the shape of the arterial wave. And, they're kind of looking at what is the rate of rise, what's the upstroke, how do the dynamics of it change after that? And they can calculate some really interesting things like LV stroke volume, aortic compliance, vascular resistance. They can look at reflection waves. Very, very cool stuff. I would say that they are very useful tools because you can put them on anyone and you can get these measures. They're not always super reliable. And sometimes when you have both invasive and these sort of non-invasive measures, you kind of see the limitations of them. But I think they're a great tool. Great item to have in the toolbox. Great way to sort of throw on something and get numbers. They may not be the most accurate numbers, though.
Yeah, I think for the purposes of this conversation, we can call them, magic black boxes that you connect to an arterial line. They give you cardiac output, index, SVR, etc. In my shop and many others I've worked with, we sort of disingenuously call them random number generators. And I feel kind of bad saying that. Everyone gives them a little chuckle. I almost feel like you hook them up because it's like easy to do. Most of your patients, they have a central line, they have an A line. You hook them up anyway. It's like no more effort. It's just work for the nursing staff, and admittedly, it is work for them because they have to hook it up, calibrate it, etc. So recognize that just because it's no work for us, it is additional workload for the nursing staff. But they do that, and then you look at the numbers and you're like, I don't buy it. And then you're like, well, why did I do that in the first place? And so
it's like that joke about any journal club article. There's only 2 interpretations. I knew that already, or I don't believe it. Like that's kind of how we approach these things too.
Right.
Though
So
I will say they can be very useful if you believe it and then you use it to trend the response to therapy.
And I think that's the kicker, right? It's like you get a value It's like well calibrated. It kind of makes sense at least, or maybe you like validate it against your point of care ultrasound, which you're
Yep.
not going to be able to do over and over again, practically speaking. And then you're like, okay, fine. And I'm not sure, Nick, you may know this better than me. I, I'm not sure if this is like true across the board or if it's like specific to the different modalities, but like I know that there are requirements in terms of like, you know, the patient status, positioning, spontaneous breathing. Like it said, like there have to be some specific like elements there.
Yeah, there are some criteria. It's a little bit less restrictive than some of the other tools that we use, like pulse pressure variation, for example. It's less restrictive than that.
Okay,
It,
yeah.
in theory, it can tolerate. I think in theory you have to be in sinus rhythm. You can be spontaneously breathing because it's not really looking at a respiratory interaction. You obviously, I think, should be lying down. The height has to be calibrated.
Right.
So there are some important caveats to these measurements.
And I suppose like and I guess to be fair, like PA catheters, ultrasounds, like all of those have their own caveats as well. So it's like it's not like any of these modalities are going to
Got
be
to know the
perfect.
limitations of every tool in the toolbox. Yeah.
Fair enough. Fair enough.
So while we're talking about this, let's talk about kind of the quote unquote gold standard or
Sure.
invasive
Yeah.
measurements. So PA catheter or Swan-Ganz catheters can give us a lot of really useful numbers. They can give us pressures, like you mentioned, the wedge pressure. They can also give us the CVP. They can also give us calculated values. And one of the things that we can calculate with this is the cardiac output and, more importantly, the cardiac index. They use a little trick to do this called thermodilution. So in the old days, you'd have to inject cold saline and measure the change in temperature from that. Nowadays, they have these things called continuous cardiac output swans. Essentially, what it has is it has a thermistor at the end that measures temperature, and it's got a heating element that heats the blood. And the way this works is that by heating a volume of blood and then measuring the change in temperature, you can figure out how much blood went by. So if the blood flow is really brisk, the temperature will only rise a little tiny bit, right? A little bit of warmth added to a lot of blood. But if the cardiac output is low, if the blood flow is really sluggish, a small volume of blood will get heated up a lot more. And therefore, by change in temperature, we can measure what the cardiac output is, or at least estimate it. What's cool about these swans is that they can cycle the heating element on and off like 2 or 3 times a minute. So you can get new values continuously, which is super cool, super useful. In summary, I would say PA catheters can give us a lot of information. They can give us information about pressures, like wedge pressure, CVP. They can also give us accurate to the second cardiac output, cardiac index. And then based on that, we can calculate other things like stroke volume, SVR, PVR. So they're super useful tools in the right patient.
Yeah. And so I think, it's kind of nice place to touch on the idea of like, okay, but PACs don't improve survival. So I think this is like a common theme, at least during my training, and perhaps during yours as well. And it's just a common theme in general. But I think the paradigm here that we discuss not infrequently is this idea of ICU nihilism versus intensivism, which is just such a great term. And I have a couple thoughts on this. I know you do too, Nick. So in the interest of time, because we have so much to cover, I'll try to be brief, which is, I know, a rarity. I think some people will cling to the paucity of mortality data, or the lack of huge positive RCTs in the ICU or in critical care medicine. Use that as a reason for not doing X. Often behind a frown, some deeply bagged, dark eyes, heavily stained coffee cup. Others, and hopefully I fall into this camp, will instead just recognize that like doing things for the sake of doing things is maybe not always the best option. It often begets complications with little benefit. And frankly, many of our patients will get better with time, tincture of time, and just kind of good general critical care. I often will say semi-jokingly and semi-not, do as much nothing as possible and just watch your patient carefully and be ready to act when acting is necessary. I often will say, oh, go ahead, Nick.
I was going to say, I mean, so it's intensivism, right? This idea of like less is often more, choose what you're doing carefully. Don't do things just because they're part of, like some protocol, but like, do they actually have evidence behind them? I think that's all great. I completely agree with that. But there's
Yeah.
this other idea of like ICU nihilism, which is that like unless there's like multiple high quality RCTs behind something and a meta-analysis that proves it, I'm not going to do it, which is basically a kind of an excuse to do nothing because we don't have a lot of evidence for a lot of things that we do. And sometimes I think it's an excuse not to think either, or to sort of grab onto a fact like PACs don't improve survival and then say, I'm never going to do this thing, as opposed to thinking about, what are the limitations of that study? When is it helpful? When is it harmful?
Yeah. And I think another part of that discussion, and something that I see in the ICU, I don't know if this fits in necessarily here, but I think when you paint with a broad brush, you often end up with a messy painting. So if you say that something doesn't work, when it does work, it's just a matter of which population you're applying that thing to. I think that it's just poor and lazy practice. So I think the PAC is a very good example of that. It illustrates this discussion very nicely.
And I think, in order to really kind of double click into this for our listeners, let's go back to the original trial, the trial that quote unquote established that PACs don't improve survival. I'm of course referring to the PAC-Man trial.
Yes. So again, 5 stars for the name. I'll give him that. So this was a large pragmatic trial in the UK, and it found no difference in hospital mortality. So 66 versus 68%. It was a randomized trial of about 1,000 patients who the clinician thought should have a PAC, but it excluded people who already had one. So maybe those would be people who, I don't know, needed one the most. And it was also in a medical ICU with a wide range of diagnoses. And so basically, based on that population with that particular exclusion that I mentioned, the determination was made by the authors that we don't need swans anymore, period.
And frankly, I just could not disagree more with this conclusion of this trial. So first of all, just like philosophically, right? It's kind of unfair to expect a diagnostic tool to improve survival right off the bat, right? Show me the evidence that X-rays improve survival, that blood gases improve survival, that routine morning labs improve survival. Fundamentally, measurements can only help us if we're using them to make important decisions. A couple of things I'll emphasize about this trial. First, it is an old trial. It was published in 2005, and it was actually done from 2001 to 2004. A lot has changed since then in critical care, and particularly in cardiac critical care. Second, only 11% of the patients enrolled in this study actually had cardiogenic shock. That's right, 11%. That means that 89% of them had some other issue where I'm not sure how useful a swan would be, quite frankly. Third, in my practice today, 2024, 2025, PACs are often used as a way to get numbers to trigger mechanical circulatory support, advanced interventions like Impella and ECMO and stuff like that. But those weren't a thing 25 years ago. So there was less upside to this therapy. And then finally, criticism of this study, they had an insanely high rate of complications. So I went back and looked, and 10% complication rate with placing a swan. They caused 16 arterial punctures, 1 cardiac arrest, 2 pneumothoraces, 1 hemothorax, and they lost the guide wire twice. All right. This is just not what modern ultrasound guided line placement looks like.
Literally never done that ever in my life.
Never done any of those things.
Yeah,
never. Right? Yeah.
So okay, I've caused a pneumothorax putting in a line. I've done that before. But otherwise, none of that.
Yeah. I think this just shows you that, medicine has come a long way. And that, this is a 1,000-person study that people think proves we shouldn't do swans. Instead, I think it proves we shouldn't do swans the way they did in this study. I do want to emphasize, though, that I don't think that the doctors back in 2001, 2004 were bad doctors. One listener chastised me for referring to the bad old days of high tidal volumes in our ARDS episode. I don't think that people were bad. I think that, knowledge has advanced, technology has advanced, point of care ultrasound has made placing swans safer. And I think that we wouldn't even think about placing swans into people who we didn't think had cardiogenic shock for the most part these days. And so I think that we have to be really careful about over interpreting an old study like this, where, the population is different, the intervention is safer, it leads to more outcomes, just like everything about this study is not applicable today.
Some people also reference the 2005 ESCAPE trial as a reason to not use pulmonary artery catheters in advanced heart failure, or extrapolate to MICU patients in general. But that was pulmonary artery catheters for heart failure, specifically not complicated by cardiogenic shock. So not appropriate. So it's
Not
again
what we're
a
talking about this
situation.
episode.
Exactly right. So it's another situation where like people are like, oh well, don't do this, but it's like you're mixing like apples and monkey wrenches. Comparing apples to monkey wrenches, I should say. So perhaps a more useful study might be the 2023 article by Kanwar and colleagues looking at over 1,000 patients with acute heart failure syndrome complicated by cardiogenic shock, which did find the all-powerful mortality difference that we're all looking and searching for, of 8%, which it was 30 versus 22%, favoring the use of pulmonary artery catheters.
And by the way, remember the PAC-Man trial? It was like 66 versus 68. That's a tribute to how far things have come in 20 years, right? From 60s to like 30s or 20s. I think, just to share my bottom line, I think PACs are incredibly valuable in the right patient, particularly those with cardiogenic shock, where you're deciding, will this person need mechanical support, and you're actively titrating interventions. I rarely use PA catheters in most MICU patients, and neither should you, but I've often used them in cardiac ICU patients where we're doing all these things, and I think other people should not be afraid to use them there. If someone is sick enough that you're going to go to the cath lab for PCI or MCS, you're doing a lot of meds, you're titrating a lot of things, you're calling cardiogenic shock team, like these are the patients where a Swan could very much help you.
Well said, Nick. So we've taken a nice little detour through our big old cardiogenic shock diagnostic tool shed. The two biggest tools are currently talking into your ear, otherwise staring at you in the face. Apologies. Anyway, we've got a few more stages to cover, so we should probably get on with it.
All right, so we talked about A, B, and C. Now things start to get a little bit more. D is depressing. No, D is like decompensated. This is where patients are really starting to, quote, fall off the cliff. So their numbers are worse. There's evidence of end organ hypoperfusion. This is people who are deteriorating despite therapy. So I think about stage D. Then we've got the final stage. Stage E is for extremis. These are your like peri-arrest moribund patients. These are people who, if they're not on ECMO or MCS now, they really need to be. And these are patients who may arrest even despite that therapy. These are generally people where they have, really significant abnormalities. They're unconscious, they're anuric, they're cold, they have an elevated lactate, they have a low pH, they have renal failure, liver failure. These are people with mortality that's like 80% plus. These are the people where hopefully we didn't get to this stage. Hopefully we acted sooner and prevented it. So covered a lot here. We talked about all the stages, all the tools in the tool shed that we can use. Cyrus, why don't you give us like a little recap so we can sort of talk, kind of step back and talk about all this.
I think so. Yeah, I think that's reasonable. So I love it. So cardiogenic shock, it's a big deal. High mortality, especially at later stages. The stages per the SCAI are based on hemodynamic parameters, labs, exam findings, as well as the interventions necessary to keep a patient alive. In general, patients progress from stage A to E, although depending on the insult, a patient's initial presentation may unfortunately be in extremis.
They may come in E, that's right.
Right.
These, I just can't help it, but like, these always remind me of like Strong Dad's like children's book. Like right. E is for extremis, F is for uct.
Oh yes, yes.
I think exactly 3 of our listeners will get that reference, right. But I'm here for you guys.
Right, exactly. And yes, and as far as hemodynamic parameters go, here the goal is really to quantify how sick a patient's heart is, and whether that sickness is localized to the LV, the RV, or the patient really does have biventricular or biV failure. And that's where those calculations we talked about will be helpful. The measurements and the calculations. So the measurements, the PCWP, the RAP, the CO, the CI. Although I guess the CI is technically a calculation. And then the PAPi, the CPO, that ratio I talked about, the RA to the PCWP, all that can be very helpful, in addition to your echocardiography, of course.
Right. So we've sort of gone through a lot here. We've talked about kind of what is cardiogenic shock and like how do we stage it, how do we measure. Now that we've talked about that, let's talk about the why behind the what, as we like to say on critical care time. Like, what is going on in these patients? Why do they progress? I think classically we think of heart failure as being a consequence of ACS or acute coronary syndromes, but that's actually kind of a minority of these cases, right? Only about, in some studies, under 15% of patients with cardiogenic shock have that in the setting of ACS. Many of them are patients who have baseline heart failure, which is exacerbated, or they have some other insult that sort of puts them into this. And I think it's really important to remember that. Cyrus, you want to expound on that a little bit?
Yeah, absolutely. So, outside of the two common causes that you mentioned, we should consider RV failure secondary to acute lung disease. This can be seen in severe cases of ARDS, for example,
Right.
myocarditis, Takotsubo cardiomyopathy, other cardiomyopathies like septic cardiomyopathy, which we mentioned earlier, peripartum cardiomyopathy, all of those things to consider.
Right. And then, we also see a lot of infective endocarditis, valve failures leading to cardiogenic shock. There are a lot of things, and you should think about cardiogenic shock as sort of a final common pathway where as the heart fails, you get end organ perfusion, you get worsening cardiac perfusion, and then you get worsening cardiac failure. So it forms this sort of worsening spiral. Yeah. I think one other point to emphasize maybe is also that, the LV and the RV are interconnected. So often patients who have an LV insult will develop RV failure as the LV starts to fail and more, and the RV is pumping against a greater afterload. I think it's also important to emphasize something we said early on, which is that often this can start insidiously. That the a presentation with a low blood pressure may not be where these people start. It may be more subtle than that, and it's important to sort of think about all of the metrics, all of the numbers.
That's very, very true. So, a lot of times, just kind of remember, how these patients can really present, right? So a lot of times, the first indication that you'll see is maybe just an increase in heart rate. So that increase in heart rate is adaptive, right? That's an increase that's meant to support the drop in stroke volume. A drop in stroke volume is not readily apparent. A drop in heart rate, though, is something that you can see in many patients, on the monitor. Um, all of this is to maintain cardiac output. Once that heart rate response is no longer sustainable, that's really when you're going to see the cardiac output drop. As cardiac output drops, systemic vascular resistance is going to rise, i.e., you're going to see that systemic vasoconstriction um, in an effort to maintain MAP. We're trying to maintain perfusion, right? Trying to defend the MAP. Um, that's helpful initially, but then as the heart is progressively failing, that adaptive response becomes kind of a burden that the failing heart can no longer bear. And so eventually you get to this point where the heart can no longer eject blood against that vasoconstriction that was initially helpful. It becomes a problem. That increased SVR becomes too much for the failing heart to overcome, and you really just end up with the inability of the heart to deliver blood and to perfuse vital organs. And that's really kind of this kind of, I guess, sad reality of what was an adaptive response in the setting of evolving cardiogenic shock.
Very well said. Yeah, I think that's a great sort of like overview of kind of how this progresses from initially sort of adaptive mechanisms, raising SVR to compensate for low CO, eventually becomes maladaptive, high SVR to pump against. There's also this sort of downward spiral we referred to of like, as the cardiac output drops, as the MAPs start to drop, now the coronaries, in addition to other organs, are hypoperfused. Now the cardiac output's going to drop even more. This is one of many mechanisms where RV failure, LV failure can beget RV failure. We also sometimes see where the RV is dilated and that impinges on the LV's ability to pump. So, I mean, I think the key takeaway here is just enormously complicated system, complex interdependencies, and as the heart starts to fail, you can see it manifest in many different ways at many different times, and it's complicated, right? That's why we need all of these measurements to assess it.
Absolutely, absolutely. Well said, Nick.
Okay, so now that we've talked about what cardiogenic shock is, why it matters, how its pathogenesis and stages evolve, now we can finally talk about something really important. How do we manage it? So, as always, your stabilization begins with ABCs: airway, breathing, circulation. Um, Maybe we should sort of establish first off why patients with cardiogenic shock are often hypoxemic. Well, there's a few reasons for this. Um, First off, there's increased filling pressures on the left side of the heart that can lead to pressure into the lungs, which causes pulmonary edema. There's also low cardiac output leading to sluggish blood flow. And this means that there's more time for oxygen to be unloaded in the tissues. This means that the blood returning to the heart, the mixed venous O2 or SvO2, is abnormally low. Sometimes it's so low that the lungs can't bring it up all the way to normal. Remember in our hypoxemia masterclass episode, we talked about this is sort of the neglected sixth cause of hypoxemia. Anyway, now that we know why people are hypoxemic, what can we do about it?
Yeah, that's great, and I love the nod to that sixth kind of cause for hypoxemia, and an often forgotten one, but an important one, particularly in this case of shock that we spent some time talking about. So yeah, Nick, a great point. So yes, identifying hypoxemia in this setting, it's important. There are obviously a number of ways that we can treat that. So how do we go about deciding what the appropriate oxygen delivery device is for a given patient?
It kind of depends on what their needs are. So, I mean, if they are only very mildly hypoxemic, conventional nasal cannula may do just fine. Um, Many patients benefit from high flow nasal cannula. This is a good option in general for people because it's fairly comfortable. People can be on it for a long time. But this is actually a situation where I think we should really delve into the benefits of non-invasive positive pressure ventilation, because I think this is a situation where that's especially beneficial. So kind of to double click on that, so non-invasive positive pressure, it does a couple of things that are really good in heart failure. First of all, you can give a higher FiO2, you can give more oxygen, you can correct hypoxemia. Second, you're going to do work for them. The machine is going to help ventilate, so it's going to reduce their work of breathing, and that's going to mean they're going to use less oxygen. Less oxygen consumption is also going to help. If pulmonary edema is a factor, adding positive end expiratory pressure or PEEP will increase recruitment of alveoli and help promote better gas exchange despite pulmonary edema. And then there's a couple other interesting benefits too. So recruiting more alveoli is going to create more places for blood to go, more open capillaries in the lung, which has the effect of lowering pulmonary vascular resistance. So PEEP is going to open up more alveoli, create more places for blood to go, and make the right side of the heart have an easier job because it's pumping against less afterload. Finally, and maybe one of the most important mechanisms, positive pressure in the chest will actually help pump blood out of the chest. If you think about it, when you have positive pressure in your thorax, there's a gradient from thorax to abdomen and thorax to upper extremities and head. And what that means is that it's going to actually help pump blood out. So that's going to increase forward flow and increase cardiac output as well. So lots of reasons to love non-invasive. One other reason that I really love non-invasive, in general, non-invasive is a great therapy when you can turn something around quickly, but it's not a great therapy if you're going to need to be on it for days and days and days. Right? That's why non-invasive works really well in like a COPD exacerbation where you can give them steroids and antibiotics and they turn around fast. It also works well in a heart failure exacerbation where you can give them diuretics and inotropes and all these other therapies and hopefully turn them around fast. Non-invasive tends not to work as well in things like pneumonia, where somebody's likely to be hypoxemic for days and days and days, because most people just don't tolerate having that fighter pilot mask tight on their face for more than about 12 hours.
Nick, I think that's an excellent discussion on non-invasive positive pressure ventilation. We're going to talk about invasive positive pressure ventilation, but before we do, one key point I did want to bring up, which is really relevant to both modalities, which is when you do use positive pressure ventilation, we want to be careful, in particular when you have kind of isolated or right-sided predominant heart failure. resulting in cardiogenic shock. And really the reason is that in right ventricular failure, positive pressure ventilation can potentially decrease preload, increase afterload, and that can actually lead to further hemodynamic deterioration. That's something that I've seen. It's something that's described in the literature. Remember that the LV tends to be a little bit more robust and actually can receive some augmentation, Nick, as you beautifully described, from that positive pressure. However, the RV often doesn't glean that benefit, and actually you can see worsening failure with positive pressure. So you just really have to be watching those hemodynamics very carefully and be mindful of that possibility. I don't know, Nick, care to comment on that?
No, I think that's a great point. Yes, very important caveat. If you think about it, we often use CVP as a surrogate for right atrial pressure, which we use as sort of a surrogate for right-sided filling pressure or preload. If you add more and more pressure in the chest, you're essentially reducing the effective preload, right? That CVP now has to overcome whatever pressure you've added to the chest. Sometimes that's good. And somebody who's massively volume overloaded, who has a CVP of 20, adding PEEP can be good. But in somebody who's, exactly as you said, somebody whose RV is failing, they depend on that preload. And taking it away effectively by adding this extrinsic pressure in the chest can often make their RV fail even further. So that's a really good point. Really important caveat.
Yeah, I mean, I think but the reality is, sometimes you need more than just nasal cannula, more than just high flow. And so we obviously need to make sure our patients are oxygenating and ventilating and all of that. That discussion of preload dovetails nicely with this idea of invasive mechanical ventilation, because one of the kind of necessary evils is this idea of induction and paralysis, providing those medications that are required to intubate a patient successfully, neuromuscular blockade. All of those things can also impact significantly your preload. And so the decision to intubate and invasively mechanically ventilate a patient with cardiogenic shock is not one that anyone should really take lightly. Fortunately, many of these patients, if identified quickly and treated effectively and appropriately, will turn around quickly enough to where you may be able to just bridge them to sufficient recovery with non-invasive, kind of just watching those hemodynamics carefully and managing them closely. But some of them won't. And so if they don't, you just have to be, I think, very careful about what medications you're using. These are folks where I'm definitely leaning on things like ketamine to try to be as hemodynamically neutral as I can, or otherwise I'm just really making sure I'm kind of pre-resuscitating as best I can prior to induction, maybe even targeting higher MAP goals before induction just to be extra cautious. Those are all sorts of things I'm thinking about if I have to mechanically ventilate and really not even it's not the mechanical ventilation so much as just the intubation itself and the medications required that I'm really just very cautious about.
Another really good point. Yeah. In our episode where we talk about the physiologically difficult airway, this is a case that comes up a lot, right? The person with cardiogenic shock is somebody who can easily code with induction if you don't do it right. Just to amplify some of the things you said there, absolutely, like more hemodynamically stable induction meds like ketamine is a good choice over propofol. I like to use non-invasive as sort of test what their response to positive pressure is going to be.
Good point.
So you can sort of like a physiologic trial of positive pressure before you put them on invasive positive pressure.
Right.
Another thing I like to do is make sure they're on all the drips, right? Make sure that I'm giving them inotrope support, vasopressor support. And then often in the setting of induction, we need to give a little bit of push dose pressor to offset the effects of those induction meds. This is a situation where push dose epi is often the right one.
Good
and
point.
Something
Really
that's
good
pure
point.
alpha, like phenylephrine, may not be your friend, because the
Yep.
failing heart giving more afterload to pump against can actually make things worse.
That's so important, Nick. I'm really glad you mentioned that, because a lot of times, like, I'm reaching for phenylephrine just because it's easy to dose, and it's just something that's like kind of and it's easy to pull. But yeah, this is a case where that's maybe not going to be your best option. And one other thought too is, if you're not going to use ketamine, this is maybe one of the cases where I might dabble in a little bit of etomidate. I'm really not a big fan of etomidate in general, especially in the medical ICU, because that risk of adrenal insufficiency and that sort of like lingering pressure requirement that you might see 48, 72 hours down the road, we've seen in meta-analyses in the last few years can be attributed to etomidate. But if we're really thinking that this is a predominant cardiogenic shock picture, I'm not terribly as worried about etomidate in that particular case. So moving on, I think we probably hit those nails on the head pretty adequately here. I do want to make sure, though, that we talk about our vasopressors, our inotropes, our other pharmacologic interventions, because those are really important before we kind of get to the toys. I know we don't want to talk about the toys too. So Nick, you want to talk about some of that, some of those pharmacologic options for us?
Absolutely. So, I mean, one thing that we want to do in these folks is we want to support their contractility using inotropes. We have a whole episode on this that you should go back and listen to. We talk a lot about how to choose the right inotrope for your patient's physiology. Are you doing this for contractility? Are you doing this for chronotropic effects? What effect do you want to have on RV and LV afterload? So those are important considerations, but you're choosing an inotrope here. Another consideration is you want to maintain enough MAP. And so sometimes you need to add vasopressors. We have a two-parter episode where we talk about vasopressors, so we get into the weeds here. As we just mentioned, though, often you want to give something that will also support the heart as well. So maybe avoiding things that are pure alpha and using other choices. Another category of medications that we lean on heavily in these patients is often diuretics. Now, not all of these patients need diuresis immediately, but often it's something that you try fairly early and often somewhat aggressively if you're seeing signs of venous congestion. We have a whole episode on diuretics as well and volume management. I think the key thing to remember there is, you're trying to maintain a perfusion pressure. There's a couple other classes of meds that we often talk about here too. So inhaled pulmonary vasodilators. This can help with hypoxemia by improving VQ matching. It can also help a failing right ventricle by lowering pulmonary vascular resistance, which is the RV afterload. And then there's a lot of other sort of small optimizations, right? There's some studies from the 1980s that show better outcomes when you keep a potassium above 4, a mag above 2, ionized calcium above 1.2. I'm not sure that that's really as life-saving as those old studies would have us believe, but they're often things that we try to optimize.
Awesome, Nick. Yeah, and I think really like to give our listeners a little bit of guidance here. I think generally what we're trying to use, or what we're really leaning on rather, would be our inotropes plus minus our vasopressors to try and achieve, a cardiac index of greater than 2.5, a MAP of greater than 65. Really trying to increase that cardiac index, maintain that adequate MAP to, keep that pump going, maintain perfusion. Keep our end organs functioning as best we can while while we get that cardiogenic shock to resolve, or hoping we can get that cardiogenic shock to resolve with all our other good critical care interventions.
Right. And I think, it's important to put the map in perspective.
Right.
Remember that, whether you're talking about the kidneys, the coronaries, or the brain, they're getting perfused by the difference between the map and the CVP. So normally right now, if I have a map of 85 and a CVP of 5, that means my kidneys and other organs are getting about 80 millimeters of mercury of perfusion pressure. But if my CVP is suddenly 20 because I have bad heart failure and my map is only 60, that means that the perfusion pressure for my kidneys is only about 40 millimeters of mercury. It's half what it ought to be. If you walk in the room and you see a patient whose MAP is 40, you recognize that's an emergency. But if you walk in a room and somebody's got a MAP of 60 and a CVP of 20, from the perspective of the kidney, that's just as bad. So we often need to think about both those numbers when we're making these decisions. We talk more about this in the diuretics episode, but recognizing that treating congestion is often the better option rather than just, trying to add additional MAP.
Absolutely. That's a great point. And really, I think it's also helpful to kind of think back to what we discussed earlier, that idea of the warm, the cold, the dry, the wet quadrants, as far as a framework. Figure out where your patient actually kind of fits, and then use that to help determine what combination of inotropes, vasopressors, and then possibly diuretics, or even administration of volume in the appropriate case. What combination of those interventions, are you going to use to achieve your goals?
Absolutely, that's right. I mean, figure out where your patient lies and then adjust physiology accordingly. We mentioned this a little bit before, but in terms of your choice of inotrope, heart rate is often one of the decisive factors. If the person is already tachycardic, adding like milrinone may be a good choice. And especially if you want to have a little bit of afterload reduction with it. In some cases, you don't want that. And so you have to do something like combine milrinone with something like vasopressin in order to sort of dial in the amount of afterload we need.
That's right. That's right. And so, yeah, again, just another pitch for, these episodes that we've done. There's some method to the madness here. So we've talked diuretics, we've talked inotropes, we've talked vasopressors on previous episodes. So if you want a refresher, please go back and listen to those. Probably reasonable to also double click on this idea of pulmonary vascular resistance. We're talking about how we're going to optimize afterload, in terms of the SVR, but we should really talk a little bit about the PVR as well. Again, that pulmonary vascular resistance. So this really is primarily going to be when we're talking about a failing RV. As the LV fails progressively, of course, that's going to beget RV failure. And so there is that relationship there to be mindful of. If we're dealing with RV failure, for example, we may want to use things like milrinone, for example, because we know that that's an agent that's going to have PVR reduction properties. Also, there is some signal for vasopressin as both increasing your SVR, but also decreasing your PVR. So it's kind of an interesting option for cases where you have a particularly sick RV. In addition to kind of like being mindful of your vasopressors, inodilators, those agents. You can also achieve greater PVR reduction when you're using pulmonary vasodilators, in particular inhaled pulmonary vasodilators, things like epoprostenol or inhaled nitric oxide. So those are agents that you may have at your institution that you can use to try to drop that PVR and improve your forward flow, i.e., delivering blood from the RV to the LV. And finally, it's also important to remember, this gets back to what Nick was talking about earlier, is that allowing hypoxemia is really not a great idea, especially when you have that failing RV, because we know that hypoxemia is going to cause hypoxic pulmonary vasoconstriction. I mean, this is a unique property in the pulmonary vasculature. That hypoxic pulmonary vasoconstriction is going to increase your PVR. It's going to increase the workload on that failing RV. And so again, anything we can do to counter that, and really they talk about oxygen as being sort of this poor man's vasodilator. Anything we can do to counter that is really going to help us out in the long run. It's going to help your patient out, which is really what's important at the end of the day.
That's a really good point. And going back to our earlier conversation about how to safely intubate these patients, avoiding hypoxemia is really important for that reason as well. That's why pre-oxygenation, short apneic interval is so crucial, because hypoxia begets hypoxic pulmonary vasoconstriction, which increases PVR, which can cause a struggling right heart to become a totally failed right heart. Excellent point.
For sure. And I just wanted a couple things. We got some graphics, I think, on the website that we created, and also, really, Nick, that you created, looking at vasopressors, looking at inotropes and the inodilators, and kind of giving our listeners and our audience some ideas to how they work and how they're balanced, which I think are great. Certainly, if you guys haven't seen those,
plug for our website.
Yeah, go check those out. There's also a nice little summary graphic that's in one of the guidelines that we reference in this episode. Basically, looking at the European guidelines, American guidelines, and what are the recommendations for where to start with these patients in cardiogenic shock. And really, it's to a certain extent, it's a lot of dealer's choice. I suppose if you have to pick one, you're seeing there's a lot of norepinephrine, actually. It's kind of surprising, kind of not surprising. I think a lot of times intuitively we think of inotropes as being the first line in cardiogenic shock, but really norepinephrine is more or less across the board what's recommended. If anything is kind of firmly recommended. And I think that really gets to the idea that so many of these patients are in some degree of a mixed shock state, or we don't quite know exactly what they're in per se up
As
front.
we said in the vasopressors episode, norepi is almost never the wrong choice.
Right,
So it's a
right.
reasonable place to start. I think there's a lot of there's not many head-to-head studies, and the few that there are don't really show clear superiority of one pressor over another or one inotrope over another. So there's a lot of dealer's choice here. I think there's a lot of institutional preferences.
Exactly.
There's a great paper I'll put into the show notes where they sort of show the preferences in cardiac surgery patients across institutions. And, it's really funny. I mean, there are some places that are epinephrine shops. There are some places that use a lot of dobutamine. There's places that use a lot of milrinone. There's a few places that lean on dopamine. It's just kind of funny. There's a lot of institutional norms here. That said, I think that the most important thing is start a med, get physiologic measurements, and then titrate appropriately, and be nervous if somebody's on a ton of norepi and they're getting worse. That should be a trigger for you that you're missing something, that this may be less of an afterload issue and more of a pump issue, and you may need more squeeze.
I couldn't have said it better myself, Nick. I think that's perfect. I think with that, perhaps we can move on to which medication should we avoid in these patients?
Yeah, and I think sometimes doing right by these patients is it's importantly about not doing wrong by them. So there's a couple of mistakes that unfortunately I see that get made surprisingly often. So sometimes people continue beta blockers or give beta blockers in the setting of acute decompensation. That's obviously not a great idea. Another one that I see surprisingly often is people will see somebody who's very tachycardic. Maybe they're in AFib with RVR, and they'll sort of fixate on the heart rate as the problem, as opposed to perhaps a compensatory mechanism. And they'll be very generous with the rate control. And in particular, the thing that really irks me is when people give calcium channel blockers like diltiazem. This is wrong for a couple of reasons. Calcium channel blockers like DILT are contraindicated in patients with low ejection fraction. Second, in many cases, the heart rate is compensatory for that low EF. So by lowering their heart rate, by quote, rate controlling them, you actually lower their cardiac output a lot. And third, depending on the circumstances, there may be a better option like rhythm control, right? I mean, remember that many of these patients probably like having atrial kick.
Yeah, I think that's a really important point. And I also think that atrial kick in particular, it's really, in most cases only going to contribute about 15% or so of additional stroke volume. However, in someone who's got a stiff heart, so someone's got diastolic dysfunction, HFpEF, they may actually really rely upon that atrial kick to fill their thickened ventricle. Don't discount the importance of that in patients like that, and in some of these patients that you might see. And also remember that cardiac output is going to equal against stroke volume times heart rate. And so in many cases, you drop the heart rate, you're often going to drop cardiac output. Now, the one other thing I'll mention is that, there are cases in general, not here, generally ICU, where it might make sense to reduce the heart rate to try to increase a patient's time in diastole, to try to increase, actually increase cardiac output or increase perfusion.
In many cases, slowing the heart down means more filling time, so your stroke volume increases. So
Exactly.
the net effect is an increase. So it's complicated.
Right. But the thing is, that those are patients that are typically very tachycardic. Those are patients who are usually not cardiogenic shock patients who don't have EFs that are really, really low. And what I would usually do is either a test dose of 5 metoprolol or maybe esmolol, where it's quick on, quick off. I would not do a big slug of, diltiazem as my test dose and see what happens. And yeah, it's something that I rarely do, not in these types of patients. So caution, caution, caution. I would be very, very reluctant to do it in this type of patient. Totally agree with you, Nick. Absolutely.
Yeah, I think we probably ought to lean on drugs like amiodarone a little bit more in these patients, especially if you're okay with them converting back out of AFib if they're in AFib. And obviously, we're going to have a whole episode on AFib coming up, so we'll delve much more into this. But I think as far as avoiding the wrong meds, don't throw a lot of beta blockers, and definitely don't throw calcium channel blockers at these patients. That's generally not what they need. All right. So now that we've talked about what what the categories of pharmacologic therapy are. We've pointed you to episodes where we talk about all of those in greater depth. Now we can talk about the mechanical circulatory support options. Like, what are the machines that we have to help these patients?
Yeah, there are several different options, and they probably each deserve their own episode, or at the very least, an episode devoted to these options. So here we're going to really just provide a broad overview and leave a lot of the details out for a future episode or two.
Think of this as we're going to take a little tour of the car dealership, but we're going to save the test driving of the fancy MCS vehicles for a future, right? We'll get into that later. I promise. I want to talk about these, but we're going to just sort of give you the overview of all the options first. So first option, commonly available, one of the older options is the intra-aortic balloon pump. This is cheap. It's available at a lot of institutions. It's generally placed by a femoral artery insertion, though it can be placed axillary as well. The idea here of aortic counterpulsation is that you have a balloon sitting in the aorta, generally anywhere from 30 to 50 mils, that is inflating and deflating opposite the heart. So it's inflating in diastole and increasing retrograde flow to the coronaries, and it is deflating with systole and helping to pull blood out of the heart with cardiac ejection. There's a lot of nuance to these. The timing is really important. You can set them so that they operate with every cardiac cycle, so-called 1-to-1. They could be 1-to-2, 1-to-3. There's different ways that you can gate them. There's a lot of complexity to these machines, but kind of the beauty of these machines is they've been around for a long time. Most centers have them. And they have a good effect on increasing coronary perfusion and some effect on increasing forward flow out of the heart.
Yeah. Now, like with really all the devices we're going to talk about, there are certainly some complications here, and those include with the intra-aortic balloon pump, complications such as injury at the access site, limb ischemia, infection, thrombocytopenia. You can have balloon rupture. You can actually see aortic dissection, which is uncommon, but of course that's suboptimal, we'll say. And you can also see mechanical failure.
Right. And so, this is a situation where when this was the only option, this was very heavily leaned on as a treatment for cardiogenic shock. But now, as there are some newer and likely better options, things are changing. So, Cyrus, you want to walk us through kind of what the guidelines say about balloon pumps at this point?
Yeah, so briefly, the ESC, or the European Society of Cardiology, has kind of downgraded routine use of IABPs in cardiogenic shock patients. And really that's reflecting kind of the findings from the IABP Shock 2 trial, which demonstrated no significant mortality benefit in this context. The ACC-AHA, similarly, they reduced their recommendation for IABPs in the use of cardiogenic shock in line with the ESC. And so this study that I'm referring to, the IABP Shock 2 trial, was a pivotal randomized controlled trial with about 600 patients with AMI-induced cardiogenic shock. And what they essentially found was that insertion of an IABP did not reduce 30-day, 1-year, or 6-year mortality rates compared to standard medical therapy. There were subsequent meta-analyses that corroborated these findings, which essentially substantiated the findings that I referenced before, indicating that routine use of an IABP in cardiogenic shock is probably not best practice in 2024 or 2025.
And I just want to emphasize one word that you just said, which is the word routine. I think all comers with cardiogenic shock definitely do not benefit from balloon pumps, but I do think that there are some patients who do benefit from them. First off, as somebody who works at like a quaternary cardiac center, I accept a lot of patients who are transferred in from elsewhere, and elsewhere, St. Elsewhere, outside hospital, often does not have the capability to do more advanced mechanical circulatory support. So balloon pump may be the best option they have, and that may be the best way to stabilize somebody for transport. So that's an important caveat. I think it's also worth remembering that there may be slightly better evidence for balloon pumps in the context of PCI or CABG. I think, all comers with cardiogenic shock, probably not a benefit to routine balloon pumps, but maybe in selected patients where it's used to support them during procedures or in the immediate peri-procedure or perioperative setting, there may be some more benefit there. And then finally, as you know, as you like to say, Cyrus, every patient is an N of one. We have pretty robust evidence that routine use of balloon pumps in all patients with cardiogenic shock is not beneficial in terms of mortality. But I think if you select the right patient, and maybe patients who aren't a candidate for something else, like an Impella or ECMO, this may be a good option to remember. I'm going to piss off the ICU nihilists out there who are chanting, "There's no benefit to balloon pumps." Well, there's probably benefit in the right patient, done at the right time for the right reason. You just have to be thoughtful about that.
Ah, yes. And speaking of Impella, it's a perfect segue to the next device we're going to talk about, which is indeed the Impella. What is it? Well, this is a percutaneous mechanical circulatory support device. It's used to assist the heart in pumping blood.
Yeah, I kind of think of an Impella as a percutaneous or temporary LVAD. It's basically a pump that's moving blood from the left ventricle into the aorta.
Yeah.
Um,
Yeah, exactly. Right. And I think of Impella, I also think of Impella kind of sounds like propeller. So it's kind of a device that has this sort of spinning screw almost. I guess it's based on like an Archimedes screw kind of concept, where essentially you've got this device. It's inserted through a catheter, typically via the femoral artery. It's advanced into the left ventricle of the heart. So this is of course for the LV assist flavor. Um,
and I think we should say, that Impella is a brand name.
yes,
Technically, you could call this a percutaneous microaxial flow pump.
yes.
But it's one of those things where there's really only one brand that's making most of this, so it's kind of like Band-Aid as opposed to like sterile adhesive strip. Like if you want
Ah,
to be
good point.
a total weirdo, yes, you can have a sterile adhesive strip. But I mean, I think this is a circumstance where even though we try to use generic terms on the show, I think Impella is probably the term we're going to use.
Yeah. So apologies to everyone. I'm going to use Impella because it's a lot faster to say. So anyway, so it's typically for the sort of LV assist flavor. It's inserted usually in the femoral artery. It's advanced in the left ventricle of the heart, positioned across the aortic valve with one in the LV and the other is in the ascending aorta. I've alluded to this. There's kind of an RP model, and that's inserted into the venous circulation. That's going to support the RV.
Right. And they're different models, they're designed different ways. You can use them together. I've had a few patients who are sort of double fisting like LV and RV support with two Impellas.
Sounds fancy.
Right. If one $30,000 device wasn't good enough, you could have two for the bargain basement price of just 60 grand.
Ah, yes, great deal. So whether it's supporting the RV or the LV, essentially, as I was alluding to, the Impella it's a small motorized pump which is drawing blood proximally and dispensing it distally to bypass the failing portion of myocardium, depending on kind of where it's inserted. So it's going to offload the heart. It's giving the heart some kind of heart rest, if you will, giving that myocardium an opportunity to recover while lowering myocardial oxygen demand.
Right. And so it's decreasing cardiac work. It's decreasing end diastolic pressure as well. Depending on the model, it can generate different amounts of flow. And we're not going to get into the nuances of that today, but depending on which exact model you have and what settings you set, it can generate anywhere from less than 1 liter of flow all the way up to about 5.5 liters of flow. And this range of support can be tailored to the patient's needs. It can be providing partial or near complete assistance, kind of depending on what the patient needs. I do want to just, remember our earlier example where we said that 5 liters could be a lot for a little tiny person, or it could be not enough for a really big person.
Yes, indeed. Yes. So, the smallest Impella is going to be more than adequate for someone, say a Tyrion Lannister type, but even the largest may not be big enough for Sir Gregor Clegane, aka the Mountain.
Wise words, Maester. You must
Thank
have
you.
you must have gotten a link in your chain for mechanical circulatory support.
Indeed, I have.
Do you have to renew that every 2 years, like your Maester chain?
Yes, indeed, yeah. It's definitely it's part of the ritual.
Gotcha.
So yes, getting back to Impella. So they're used for short-term support. They definitely need to be monitored closely. This is one of the important things. So positioning is key. Malpositioning may lead to complications. And what are those complications? So things like vascular damage, valvular damage, hemolysis, and thrombosis, to name a few. So big big issues here potentially.
I have a whole one pager about this where we really go into depth about how you use the device, what the measurements on the device, and how you can use ultrasound to make sure it's positioned, avoiding malposition. So, more on this later. We'll link to that for now. Okay, Cyrus, what do the guidelines say about Impellas?
The guidelines are quite a bit more favorable as they relate to Impellas versus the old balloon pump. And so the ESC, the 2021 ESC guidelines for acute heart failure management, have elevated the recommendation for short-term mechanical circulatory support systems, such as the Impella. Again, it's a brand name, I'm sorry. From class 2B, which would be may be considered, to a class 2A, which is a should be considered for patients in cardiogenic shock. The ACC AHA. They have limited specific recommendations. They do acknowledge the role of devices like the Impella in cardiogenic shock management, and they emphasize that really individualized patient assessment and the importance of clinical judgment is kind of paramount when considering implementation. So they kind of like
they hem and haw a little bit.
Yeah, they do. But the Europeans, at least, they kind of like they stake their claim. They stick a flag in the ground.
That's right. They're a little rude about it, but they speak their mind.
Indeed.
So there's a pivotal trial we need to mention here.
There's a pivotal trial, and it's got a great name. It's the Danger Shock trial in 2024. I feel like you have to say it with gusto. Danger Shock. So it's a randomized controlled trial, which demonstrated that routine use of the Impella CP
There's
device.
That word again.
That's right. But routine use of the Impella CP device in patients with ST elevation, myocardial infarction, so STEMI, complicated by cardiogenic shock, resulted in a significant reduction in 180-day mortality compared to standard care alone. So routine use, significant reduction. That was 45.8% versus 58.5% with a p-value of 0.04. And just to get a little more granular there, so patients got 48 hours of optimized Impella therapy if they were randomized to that group. And then the other group could get mechanical circulatory support if they needed it.
Yeah, so I think really important study. We talk about this study all the time where I work. I think this study really expanded use of Impella. I think the same way that good studies demonstrated that routine use of balloon pumps is probably not beneficial. This actually shows that there's probably a subset of patients with cardiogenic shock where routine use of Impellas are beneficial. I guess I'll comment and just say 5 out of 5 stars for the trial name. Second, this is really important. But I want to emphasize that the study also had a very significant rate of complications. Like it was 24% in the Impella group versus 6% in the control group. Those complications included bleeding at the site, which is a frequent one, limb ischemia, hemolysis. And so I think, this is a very strong argument for using Impellas, not routinely, but when you need them, and taking them out as soon as you don't need them. We should be aggressive about supporting people with cardiogenic shock, but we should also be aggressive about weaning that support as soon as they no longer need it, because mechanical circulatory support comes with significant risks.
Love it. Couldn't agree more, Nick. I think the last sort of mechanical circulatory support modality that we're really going to talk about here, not the last one that's available, but the last one we're really going to focus on is VA ECMO. Note that we are going to talk about ECMO in subsequent episodes, and we've actually got an intro to ECMO episode coming up very soon. But we would be remiss to skip it all together here. So, Nick, maybe what are we talking about here? What is VA ECMO?
So VA ECMO or veno-arterial ECMO, in broad strokes, what you're doing is you're draining blood out of the venous side and you're returning it on the arterial side. So this entails 2 cannula. Generally, there's many different ways to position the cannula, but it may be a femoral venous cannula draining blood. It may be a femoral arterial blood returning blood. You're getting retrograde flow in the aorta. The idea is that the blood is pumped out of the patient. It goes through an oxygenator or a membrane lung, which is going to remove carbon dioxide, add oxygen, and then it's going to get pumped back in. So you're essentially replacing both the heart and the lungs and bypassing them both.
Yeah, and of course, this does sound like a very appealing option, and in some cases, it's the only option. So, for example, in these ECPR cases, where the patient is in that stage E, they're
Extremis.
right, or I guess ECMO, they're receiving ACLS, and then they're sort of cannulated as a last ditch effort to save their life. But really, short of ECPR, the data isn't as positive as we'd like it to be.
Great physiologic reasons to believe in this, but
Right.
not as much trial evidence as you might think.
Indeed. And so, again, the ESC suggests that VA ECMO could be considered in patients with refractory cardiogenic shock. But they caveat it by saying when other mechanical circulatory support devices are inadequate or contraindicated. And then they say it's kind of based on expert consensus, and it acknowledges that the data is pretty limited, and that the availability of VA ECMO is also limited. Now, the AHA kind of more or less echoes that. So it's potential intervention. They emphasize the need for careful patient selection, as is often the case with ECMO in general, and the importance of a multidisciplinary team when making the decision here. There are a couple studies I think that are worthy of emphasizing here that are particularly relevant. So one that I will mention is the ECLS shock trial in 2023. So this was a randomized controlled trial which evaluated the efficacy of VA ECMO in patients with acute myocardial infarction complicated by cardiogenic shock. This study actually found no significant difference in 30-day mortality between the VA ECMO group and the control group receiving standard of care. Almost the same, 47.8 versus 49%. Relative risk there was 0.98. The 95% confidence interval was 0.80 to 1.19 with a p of 0.81. And not
Astoundingly negative.
Yeah, unfortunately, and really not surprisingly, of course, VA ECMO was associated with higher bleeding rates, more complications in general, limb ischemia, all of that not so good stuff. So not a super not a great study for those of us that that are kind of big fans of ECMO in general.
Though again, I mean, I think the routine is the problem here, right? I wouldn't take every patient with acute MI leading to cardiogenic shock and put them on ECMO. It's only a subset of those patients who really need it. And often the nuance of patient selection isn't really captured in the trial enrollment criteria. Otherwise, it would be a huge trial because you would be saying no to a lot of patients, right? And so I
Mm-hmm.
think this is a situation where it's an N of one situation. You have to decide. I'll point our listeners to the Lancet meta-analysis, also from 2023, where they looked at individual patient level data, incorporating results from 4 RCTs, and concluded that routine use of VA ECMO in infarct-related cardiogenic shock did not confer a survival benefit. There was no difference in 30-day mortality. And so, we're big fans of ECMO in general on the show. We talk about it a lot in the ARDS episode. We have an upcoming episode on it. But I think there's a couple of things we have to just, mention. It's very expensive. It's very labor intensive. It has a lot of risks, as we mentioned, bleeding and limb ischemia and problems with cannulation and everything else. And I think it's also important to remember that as the standard of care has improved, there's better options for revascularization. There's better options for pharmacological and mechanical support with things like Impellas. And so fewer and fewer patients maybe require VA ECMO. That said, I believe in it in cardiogenic shock in the right patient. And I think, kind of just to echo what the European guidelines say, patient selection, multidisciplinary team approach is important, particularly in patients where they've sort of failed other MCS and you're escalating to ECMO, or in people where other forms of MCS aren't an option.
Great points, Nick. Great points all around. Now, we are not, of course, cardiologists, certainly not interventional cardiologists, but I think we would be, remiss once again not to discuss revascularization at least briefly. So, what do you got for me, Nick?
Yeah. So, I mean, obviously, not all heart failure is ischemic. In fact, In one large study of people presenting with cardiogenic shock, only about 40% had an ischemic cause. But for people where there is ischemia, we should do everything we can to fix the ischemia. And this is a situation where collaboration with interventional cardiologists or perhaps cardiothoracic surgeons, depending on the exact vessels involved, can be really beneficial, right? Fixing a narrow coronary, which is what's causing their cardiogenic shock, is the right thing to do. You know, Often this is an opportunity, especially if we're doing this in the cath lab, to also place mechanical circulatory support and maybe other sort of things like a swan at the same time. So we can do this at the same time as other interventions. Obviously, this is probably deserving of a whole conversation, when to revascularize, when to choose which option. We should probably have a cardiologist and a CT surgeon join us in the future, and we can talk about that.
Oh yeah, I think without a doubt. And similarly, we're obviously alluding to this multidisciplinary approach, which is critically important. But getting away from the kind of heart itself is how are you going to manage the other elements here? So fluids, kidney management. Obviously we need to be very diligent about fluid resuscitation, which may be part of this, and then of course diuresis, things like CRRT. So I think up front we want to be parsimonious with our use of fluids and very diligent and very deliberate. But then as we're sort of caring for this patient further down the road, a lot of times this question is going to come up of is this a case where we're going to want to use CRRT? And the reality is, well, there's nothing really magical about CRRT. I would say in general, save for like, I suppose renal replacement therapy for toxin removal is one thing, if we're talking about like an overdose or something along those lines. But when we're talking about volume removal, there's nothing magical unless the patient simply is failing diuretic therapy and can't do it on their own. Then it's like, okay, you're kind of left with that modality. However, there's just a great deal of equipoise in terms of when do you do it? How do you do it? There's no magical modality. You've got studies like ELAINE, which support early renal replacement therapy. Then you have a KIKI, which supports delaying. It's just like, it's very much dealer's choice again, just like we were talking about with our vasopressors and whatnot.
I think, our listeners should probably go back and listen to the excellent episode we did with Dr. Kevin Chung, where we talk about CRRT, and we get a little bit deeper into talking about these studies and another situation where patient selection can be challenging.
I totally agree. I mean, really, I think the bluff here is going to be, or the bottom line up front is really medical management is key. This idea of Zentensivism is probably the way to go. If you do commit to CRRT or CKRT, commit. And then I would also say that, we're definitely going to include this in the website, but the NCSI algorithm for how to approach these patients is just a gold mine. It's like incredibly valuable in terms of giving you a pathway to follow. It touches on all the different elements of a comprehensive approach to care. The importance of that multidisciplinary team, those shock teams. It's just really, really awesome. And I just can't brag about it enough. It's beautiful.
Yeah, I think it's a great approach. One final point here is that I think good cardiogenic shock care is also just good ICU care. In general, these are sick ICU patients. We got to cover the basics. Basics include things like early nutrition, early mobility, avoiding delirium, being aggressive about weaning devices when they're no longer needed, getting lines out, and trying to minimize unnecessary therapies. Because often these patients are sick and they're going to be sick for days. And small optimizations on day 2, day 3, day 4 can have a huge impact later on when you avoid delirium, when you avoid neuromuscular weakness, etc. So we've covered a lot of ground here. We've kind of poured this massive foundation of pharmacology, mechanical circulatory support. Let's put that foundation to use with some cases.
Love it. Let's do it. All right, so here's a case for you, Nick. So we got a 65-year-old gentleman who came into the hospital with chest pain. He was found to be having a STEMI. He went to the cath lab. Stent was placed in the LAD. He's brought to the ICU. He gets to the ICU. He's chest pain free. However, his nurse reports that he does not look good, quote unquote. So never a good sign when the nurse says that, obviously. He's got a blood pressure of 90/45. His MAP's about 60. His heart rate's 110. And his respiratories are at about 24. Sat's 90% on 6 liters. Urine output's about 10 cc's an hour. Skin is cool, pale. Lungs are crackly. You get a set of labs. They're trickling back. First thing that draws your attention is a lactate of 5. So what are you thinking?
Okay, so lots to be worried about here. First off, let's recognize that this person has a quote unquote normal blood pressure, SPP of 90, but they're clearly in shock, as evidenced by skin, mentation, oliguria, rising lactate, etc. So got to recognize that this is an emergency. If we were going to stage this person, they're probably at like stage C cardiogenic shock. But let's throw a probe on and take a look. We can confirm that he's in shock. We can measure some things like cardiac output, cardiac index during a VTI. We get a lot more information to guide us.
Awesome. So you grab the probe, and as you're looking at him, you see that he actually, fortunately for you, he did come back with a swan. Swan hasn't been hooked up yet, so you don't have those numbers quite yet. So it's very savvy of you to grab that probe. Being the smart intensivist that you are, you asked the nursing staff to go ahead and get the swan hooked up. But as they're doing that, you take the probe, you get a great shot of that LVOT. You take a measurement of that LVOT VTI, grab a measurement of the aortic valve, look at the heart rate and everything like that. You estimate the cardiac output to be about 4 liters per minute.
Okay. Superficially, that sounds good, but maybe not. To our earlier point, we have to kind of know how big he is and put that in context, turn that output into an index, as we always say.
Exactly. So, if he's, small person, that's one thing. Big person, maybe not such a great thing. So great reminder to look at it in terms of index and not output. So good point, Nick.
I guess we could get more math in a second, but as we're getting the swan back, maybe we should start thinking about doing some other numbers so we can use our cardiac output calculation or cardiac power output calculation. Listeners, remember 2 things. First of all, CPO is your cardiac output times your mean arterial pressure divided by 451. And more importantly, remember that it's on our website. You just go there and there's a calculator. So you don't have to remember anything except www.criticalcaretime.com.
Nice.
So just to do that math out loud here, because everyone loves hearing people do math. So blood pressure was 90/45, you said, with a MAP of 60. We got a VTI measurement of 4 liters per minute. So we're going to multiply 4 times 60 divided by 451. And that comes out to be 0.5 watts. And so remember that less than 0.6 watts is indicative of hemodynamic compromise, and it's associated with increased risk of mortality. So this kind of confirms our worries, right? I mean, we see that the LV isn't working. We can quantify his cardiac output, and we can take the product of cardiac output and flow, and we can calculate cardiac power, which is also bad. So we're in at least stage C, cardiogenic shock.
Absolutely. Yep. And so we'll say that you get that swan hooked up and pretty much validates the cardiac output that you got with your point of care ultrasound. So yeah, we're happy with the measurement, but not happy with the value. So okay, cool. Person's in a cardiogenic shock. And we'll just go ahead and just for the purposes of this particular case, we got a PAPi. The PAPi was reassuring. We're going to talk about that in subsequent cases, of course. But we calculated a PAPi was reassuring.
Enough math at once.
Exactly right. So with that CPO that is not so reassuring, what, Nick, do we want to do next?
All right. So first off, this guy had a STEMI, or we want to make sure that he's not having a STEMI. We want to make sure he hasn't thrombosed that beautiful new coronary, beautiful new stent in his coronary. So let's get an ECG. Let's do that immediately. We've got the ultrasound out, as best as we're able to. We want to look at regional wall motion and try to see if it looks like, that LAD distribution is affected. I think we want more data. So we've got a swan, you said, so we can continuously measure cardiac index. We're going to want to start doing that. And then once we have sort of a baseline number, I think we need to think about a trial of inotropes. We also need to think about a trial of diuretics because, as you said, he's got crackles, he's got hypoxemia. So probably you mentioned that he's a bit tachycardic. So could either do dobutamine and just be careful of the heart rate. That's probably what I'll start with. So start him at like 2.5 to 5 of dobutamine, give him a big slug of furosemide, and kind of see what that does for him.
Awesome. Okay.
The other thing I want to do, depending on the how your hospital works, your mileage may vary, but probably want to get a formal echocardiogram as soon as possible. So have a technician come in who can really quantify the different walls movement and really kind of give us like a nice picture of like, is this a coronary territory or not?
Clever, very clever. Yeah, I think that all makes great sense. So, so I'll give you a little bit more to chew on here. So you get an ECG. It does not show a STEMI. You go ahead and call the echo technologist in. They do a TTE. It shows you that there's global hypokinesis. As you saw, there's an EF of about 15%. So
and actually the word global in that sense is kind of both reassuring and worrisome, right? It tells us it's probably not his new stent which is down. It tells us that his everything is down.
Right. So yeah, not which is I mean, yes, definitely not reassuring and like oddly reassuring, but then really not reassuring, I guess, in a global sense of the term. So anyway, you set them up with some dobutamine. Cardiac index improves slightly from about 2.2 to 2.4. You hit them with that dose of furosemide. Urine output improves to about 40 cc's an hour. Unfortunately, you don't get much benefit in terms of capillary refill. Skin remains cool, and not surprisingly, his repeat lactate is about the same. So you get 4.8 or so. And just to make things even a little more interesting for you, his oxygenation continues to worsen. And so now we're trying to decide, in addition to managing his cardiogenic shock, you've also got to manage his oxygenation. So what are we going to do for this guy now that he doesn't seem to be responding as well as he'd like to your initial interventions?
So a couple of things. I think it's a situation where we can try non-invasive. Hopefully we can turn this around fairly quick. If he tolerates it, that might support him for a few hours and sort of, give us an opportunity to avoid intubating him. I want to call my colleagues, interventional cardiology. I think we have to get him back to the cath lab. Two things there. One, I want to make absolutely sure his stent is still patent. He hasn't jailed some side branch or something. I also want to have a conversation about whether he would benefit from mechanical circulatory support. I think to our earlier conversations, this might be a guy who needs some support, both to perfuse his coronaries and to maintain systemic perfusion, increases his cardiac output. So a balloon pump might actually be beneficial in this guy.
Love it. Okay, awesome.
And I'll just add one other thing, which is that, he's already got a swan, which is great. But if he didn't have a swan, now would be a perfect moment for them to put one in using fluoro. Like I love placing swans, but I also love having my colleagues do it where they have all the toys and they can do it faster and easier than me. So put that on them if you need it.
Yeah, I think that's a great point. I'll say just to sort of double click on that, as you say, Nick. Every time a lot of times in my shop, we're co-managing these folks with cardiology. And I will say 100% of the time when a patient like this doesn't have a swan and I bring up, hey, maybe we should put a swan in. How do you guys feel about floating a swan? Those patients end up in the cath lab where the swan gets floated. Like they never get floated at the bedside because they're like, oh yeah, we'll just take them down to the cath lab and do it. So, I mean, I think maybe there's a reason for that. I agree. I mean, it's like, yes, just because you can do it at the bedside, if you can safely move that patient to a place where you have the resources to sort of verify position and do it in a technically easier and perhaps safer and more precise way, why not do it that way?
And honestly, how many patients are there who need a swan but don't need something else?
Exactly.
It's the patients who need the something else who benefit the most from the swan. So you might as well get both at the same time, and that way, I mean, if it's like that silly Pac-Man trial, right? Like if somebody's going to lose a guide wire, it's going to be them, not you.
Right. Yeah. That's a great point too. It's like, generally speaking, if you're thinking this person needs a swan, they are probably a candidate for something else. And so kind of killing two birds with one stone. Great. Okay. So you interface with cardiology. They confirm that the stents are open, but agree that this patient needs MCS. And so they place a balloon pump and verify that your, swan looks great, which is awesome. And then get the patient back to the ICU. Now, with that balloon pump in place, your blood pressure is 110/60, your MAP is 77. Skin is warm, cap refill has normalized, urine output's 150 cc's an hour, which is, of course, great. You got a CVP at 12, your wedge pressure is 14, COCIs now being measured by that functional and well-positioned pulmonary artery catheter, and your index is now 3 with a lactate of 2.
Excellent. So everything has moved in the right direction. Before, I think it's tempting sometimes when you put somebody who's in like stage C shock on an inotrope and their index improves a little bit to sort of celebrate that improvement a little bit too soon. Going from 2.2 to 2.4 before probably wasn't enough because he still looked bad. His cap refill wasn't better. His lactate was essentially unchanged. But now all of those things are dramatically better. He's making more urine. His skin looks better. So that's really, really reassuring. I think, the next sort of thing we need to think about is titrating these meds. Can we wean him off non-invasive? I don't love having somebody be dependent on non-invasive for a really long period. So maybe once he's gotten, a couple hundred cc's of urine off and his filling pressures have come down a little bit, maybe we can take him off non-invasive and try high flow instead, perhaps. I think, the other sort of backing up a step, the other question we need to think about over like the coming maybe 48 hours or so is how long is he going to need that balloon pump for? Did his heart take a hit and is it turning around? This is somebody who is out of immediate danger, but they're still in peril. They need to be monitored very closely in the CVICU. And, even as things start to turn around, we want to be careful to monitor closely, use the fact that we have continuous measurements to make continued informed choices every step along the way.
Yeah, all great points. I mean, we don't have a great slam dunk explanation for why there's now global hypokinesis in this guy. You can conjecture that it's there's perhaps some penumbra of stunned myocardium in the setting of this STEMI. Maybe there's a stress cardiomyopathy superimposed on the STEMI. I'm not sure exactly.
Or that he had, he took a hit because of his infarction, and then he had a, relative low flow to his coronaries.
Sure.
Remember that, your coronaries are perfused in diastole, and if your diastolic pressure is low, as his was when we met him, that his coronaries may be pretty upset.
Yeah, exactly.
It's also worth remembering too that, just because they only placed one stent doesn't mean that he doesn't have other areas that are pretty narrow. So there might have been several places where he, the combination of low flow and narrowed coronaries led to like a type 2 MI kind of picture on
Great
top
point.
of his type 1 MI.
Great point. Yeah, you can definitely have additional coronary artery disease that's not intervened upon. But just because it's not intervened upon doesn't mean it's not clinically significant, especially in the state of low flow. That's a great point. The other thing I was going to mention before we move on is, I think very appropriately, Nick, you'd mentioned was a major vessel or significant vessel jailed in the deployment of the stent, which usually you assess that or you account for that when you're deploying a stent. At least the interventionalists do. Sometimes
we love talking like we deploy stents every
day. Right? I should say like the interventionalists do, having been in the cath lab when they do this, or you can see certainly like dissections of the coronary arteries or other sort of complications, which again are typically caught in the cath lab. The other thing you mentioned is like an in-stent thrombosis. I'm not aware, and again, huge caveat, I'm not a interventionalist. My understanding is that occurring like very quickly on the heels of like a stent deployment would be pretty unusual, like really quickly having an in-stent thrombosis if that person is appropriately anticoagulated and then on dual antiplatelet. Unless there's some like kind of unusual complication. I don't know, Nick, if you've seen like
I've seen it before. I mean,
ones.
Usually you'd see that in the context of somebody who was like relatively low flow.
Sure.
It's also sort of a question of like, what is your strategy? Have you loaded them with Plavix? Have you used like something IV instead. It kind of depends.
Right.
I think there's maybe a recency bias because I've seen that like in the last year. But
The
yeah,
one thing I was going to mention is like the cases that come to mind that I've seen a few times in my career are not kind of immediately on the heels, but kind of within a fairly short period of time where you have these like rapid metabolizers of
yep.
Plavix. And those
Hmm.
are the folks that are like, I mean, we typically nowadays you'll hear about genotyping these folks and determining
Yep.
whether they're maybe a better candidate for something like ticagrelor instead of
Hmm.
clopidogrel. But yeah, that's another thing to consider is like these folks who maybe are rapid metabolizers and they're actually, you think they're on dual antiplatelet therapy, but they're really on like single antiplatelet therapy because they're breaking down that clopidogrel so quickly. And so
Yes.
those are the cases where like they really are at high risk for instant thrombosis that can occur, I suppose, actually maybe pretty quickly. I don't exactly know the timeline, again, not being an interventionalist, but yeah, those are cases I think
No,
about where it's can be
that's an excellent
worrisome.
point. Yeah, we don't want to go down this, giant rabbit hole of
Yeah.
like, pharmacogenomics here, but I think it's a fabulous point that there's a subset of people who are set up for that. The other place where I've seen that many times is non-adherence to antiplatelet
Yep.
therapy in the
Yep.
first month, because remember that stent, until it's endothelialized is quite thrombogenic. So, sometimes you'll see this where somebody is on dual antiplatelet and then they go home and then there's like an issue with their insurance. They don't take it and they come in with an instant thrombosis. So yes, many, many different ways that you can get this bad complication. And as an intensivist, I think the most important thing that we can do is to worry about it and to advocate for these patients going to the cath lab to take a look, because,
Yes.
it's a hard diagnosis to make without looking at the coronaries.
And I think as two of your friendly village intensivist podcast hosts, the best thing we can do is bring a cardiologist on to maybe delve into this a little deeper in the future.
Sounds great.
Awesome. All
Okay,
right.
I've got a case for you now.
Great.
So, this is in a different ICU. Like many things in medicine, cardiogenic shock can occur outside of the CV ICU. So this is a 24-year-old man who comes in after a motor vehicle collision. It was a head-on collision. He had significant sternal trauma, chest versus steering column. As his musculoskeletal injuries are being assessed by the trauma team, he's noted to have a, quote, borderline BP, or, quote, soft blood pressures, despite a negative fast exam. An EKG is obtained, which is notable for ST and T wave changes in an inferior distribution, not consistent with STEMI, but definitely concerning, especially in a 24-year-old. When you go to see him, he's got clear ecchymosis and chest wall deformity. Labs are notable for an elevated high sensitivity troponin. So Cyrus, what are you worried about? What do you think is going on here?
Yes, it's definitely a classic scenario that we'll see, especially if you're working in a trauma center, trauma ICU. And what I would be worried about is blunt cardiac injury in the setting of a motor vehicle collision. So recall from an anatomy standpoint that the right ventricle is sort of the most anterior structure as in terms of the heart itself. And so it really is important to be vigilant in these cases and watch out for cardiac injury and really not miss the forest for the trees. So what I mean by that is in ATLS, we often talk about this idea of distracting injuries. So for example, this guy could have a compound tib-fib fracture where you've got bone piercing the skin. It can be a really gruesome looking, and everyone can be really focused on that. And you can miss something like EKG changes and troponin elevation, or something that can be really actually a kind of big ordeal in the long run than what may look gruesome at the outset, but something that's frankly relatively treatable with open reduction, internal fixation, and some ANSEF. And so what I would be worried about here is an injury to the right ventricle in particular that could eventually be tipping over into RV predominant cardiogenic shock.
Great. Exactly. Yep. I think there's a tendency for people to not worry about cardiogenic shock in younger people or in people who have, another clear reason for why they're in the ICU, especially if it's not a cardiac ICU. In this case, it's like a trauma surgical ICU. So yeah, absolutely. The most important thing is to be vigilant, and you are. Um, all right. What other data do you want? What else do you want to do? First couple of things to get more information.
Yeah. So, I heard we tried to do a fast. I'm wondering if maybe my imaging is, I'm crossing my fingers, good enough for me to get a TAPsy or something like that. How's my bedside echo?
Not awesome. He's
Okay.
got these chest deformities, doesn't love you pressing on his chest.
Got it.
You think maybe with a subxiphoid view that his RV looks dilated and hypokinetic, but you're probably not going to get a great TAPsy measurement in this guy.
Okay. Got it. So tough situation. So, sounds like if this is someone who had, progressive respiratory failure and you're going to be intubating them, then maybe it would be a good candidate for a TEE. Another throwback to our episode with Ross Prager discussing TEE in the ICU, of course. But I don't think this is someone who's going to be intubated here imminently. So maybe a good time for a pulmonary artery catheter.
Right. I completely agree. So if you're going to intubate him, get more data. If you're not going to intubate him, get more data. Let's just say that that he's protecting his airway for now, waiting for family to come in, et cetera. So you don't want to just intubate him right off the bat. He doesn't need it. So you go ahead and place a PA catheter and you get the following numbers. I will do the math for you here. So a CPO of 0.65 watts, a PAPi of, let's call it 0.8. Right atrial pressure of 16, pulmonary capillary wedge pressure of 10. Let's say that his lactate has gone up and, there's no evidence of post-surgical or ongoing blood loss. So how do you put this all together?
Awesome. Yeah. So it sounds like, we've gotten this guy, kind of things have moved along. We've gotten this guy, at least his initial operative intervention. We've got him up to the ICU. It doesn't look like this is a sepsis type picture. And so we're really worried about that RV, right? So the numbers you gave me, Nick, are pretty consistent with what I thought was going on. That PAPi of being, less than 0.9 is pretty consistent with a failing RV. If you couple that with a CPO that's, I guess, semi-reassuring, or at least barely, it's greater than 0.60.
It's barely, yeah,
Barely,
exactly. I
right?
mean, I think if we'd rounded a little differently, we would have gotten a different answer. But yeah.
Yeah. I mean, it's a lot of times with blunt cardiac injury, it's yes, the RV is the most anterior structure, but I think it's somewhat unusual that the LV will escape totally unscathed. So it's not surprising to me that the CPO here is borderline at best.
And also one important thing to remember too is that we often think about a failing LV causing the RV to fail because of, quote, backup of fluid. But remember that a failing RV, if it gets big, it can sort of press over and limit LV filling because of intraventricular interdependence.
Absolutely.
So, it's not always, you can't always blame the LV for the RV. Occasionally you can blame the RV for the LV.
Absolutely. I mean, the classic example of that is pulmonary embolism, but it's not
Exactly.
it's not only pulmonary embolism that can do this. Right. So anyway, really all of this is making me think that our cardiac injury is really now manifesting as cardiogenic shock, primarily due to this failing RV.
Great.
We also, we didn't talk about this necessarily, but if you did some other, other measurements or whatever, remember like a normal right atrial pressure 7 or 8 is what we typically think about. So, for example, if you're taking some additional measurements, I would imagine this person's right atrial pressure
He's
might
a 16. We said,
okay.
yeah.
Oh yeah. Okay. So 16. Okay, perfect. So, so this guy's right atrial pressure of 16 is not great. And then, you mentioned the wedge. Sorry. Yeah, I know. I totally spaced out.
I threw a lot of numbers at you all at once. Yeah.
Yes. So
the wedge is 10.
Yeah. So right atrial pressure 16 is high. A wedge of 10 is reasonably normal. So again, it's going to kind of point me towards the right side of the heart. So I think that's really the biggest issue here, with the caveats that we've already discussed.
Excellent. Yep. So you cracked the case. RV failure due to blunt trauma. So now that we've solved the mystery, do we walk away, or what do you want to do about it?
Yeah. So I wish I could walk away. The problem is as we talked about before, LV failure and RV failure, I think we're going to try to kind of do our own episodes on those individually, because I think they really do deserve their own discussions. RV failure in particular scares me because it's challenging. It has its own unique challenges, I would say. And then when you take it one step further, so when you look at blunt cardiac injury and you look at like mechanical circulatory support, for example, and the utility of mechanical circulatory support in blunt cardiac injury, when you look that up in PubMed and you remove all the filters, there were exactly 5 hits that I was able to query, which is pretty wild to me. I didn't expect there to be like thousands of them, but 5 is like pretty paltry.
So you've read literally everything on this subject?
Correct. Yeah, you could say I'm the world's expert as it relates to PubMed, publications on this. What I can say, again, this is like Cyrus Askin's experience as having trained as a fellow with some like in a trauma center with some really brilliant military physicians with combat experience. I think the approach in general is going to be to lean on good critical care fundamentals, which is often the case. I mean, this is often what we lean upon when we're like, yeah, I don't know exactly the specific thing to do here, so I'm just going to be a good intensivist and cross my fingers and hopefully that'll work. And of course that's also combined with kind of vigilant monitoring. So I think that pulmonary artery catheter is helpful. I think TEE is helpful if this person again has an airway. I think an initial TEE and then like recurrent TEE can be helpful here if you have the ability to do that. The big thing I'd want to watch out for in particular is tamponade. So that's one of the big concerns with blunt cardiac injury. Again, with that morbidity and mortality. Other than that, I think that norepinephrine is often going to be your vasopressor of choice, as we discussed previously with cardiogenic shock. In a lot of cases, that's kind of what's recommended here. I think that's still going to be true. I don't think you'd be wrong to try dobutamine or to try milrinone, but you just have to really watch carefully for the patient's response. And then again, as we talked before with cardiogenic shock, volume resuscitation, this is a patient who probably did lose some blood, so you're going to want to refill the tank, as it were, but I think overfilling the tank is where you get into trouble. And I think in trauma, the potential to do that is a little bit higher just because of the nature of their initial insult, what brings them into the ICU. So just watch these folks very carefully. It's just that idea, the Goldilocks principle here is just kind of resuscitating them just right. Goldilocks principle, if you will. And then finally, I think as far as mechanical circulatory support goes, I think really PubMed says
no evidence to guide us, right?
Exactly.
I think we know from the guidelines that routine use is probably not appropriate here, but
exactly,
we don't really know what routine is in this patient.
Who knows? I mean, like you could try to put in an Impella RP and provide that right-sided support, but I'm not sure if that blunt cardiac injury in any way, shape, or form would make that more technically difficult. So that would make me a bit worried versus something like peripherally inserted VA ECMO, which might actually be slightly safer, keeping you away from the myocardium in that particular case. So I don't know. I think I'd probably lean heavily on my supportive care, watch very carefully, vigilance, and then I don't know, man. I think I'm almost leaning, if I have to do something mechanical, I'm probably leaning a little bit more towards VA ECMO if I have to do anything at all, assuming I have that available. I don't know. What do you think, Nick? Have I lost my marbles here?
Yeah, it's a tough case. That's why I gave it to you. I think, there's a lot of competing risks and challenges here. I mean, I think your instinct is the right one, which is kind of like what Immanuel Kant would call like the categorical imperative, like do what's right, what's always right, lean on good fundamental ICU care. You're not going to go wrong with that. I think, starting with inotropes, great idea of giving the volume cautiously. Kind of, you have a swan now, so you can kind of use that to sort of assess have I adequately restored these filling pressures. The concern would be if you overdo it and you distend that RV more, you can make the failure worse. So caution there is prudent. It's going to be tough because any MCS is going to come with a potential need for anticoagulation, which in a trauma patient, and especially somebody with cardiac trauma, you're kind of nervous about. I'd be worried about turning like a little tiny pericardial effusion into a massive hemothorax with like full anticoagulation. So I think I'd probably, just like you said, like lean on my multidisciplinary team, make decisions together, reassess frequently, ICU fundamentals. And if my hand was really forced, VA ECMO, peripheral cannulation would probably be the better option. I'd get really nervous about putting cannula through an injured RV. I mean, there's probably people who would do it. I don't know. I mean, like you said, I don't think there's a right answer here. I think there's a lot of wrong answers. And I think just like caution, reevaluating frequently, focused on fundamentals is not the wrong choice.
I think the good thing to remember is that, and at least this is, I can really only speak to my experience here because there's just not a ton of literature to support this, but taking care of these patients in the trauma ICU, most of them, fortunately, are on the younger side, tend to have fewer comorbidities, and they tend to get better with supportive care. They tend to get better with time and supportive care. So fortunately, you're not having to make a lot of these really hard decisions all the time. Rather, you're just having to support them through their other injuries, the other issues that crop up, and the blunt cardiac injury tends to resolve itself with time. So,
absolutely.
Yeah.
Shall we do another case?
All right, perfect. Yeah, I think we spent quite a bit of time talking about that blunt cardiac injury. How about I send another one your way?
Do it. Send
all
it.
right, send it. Full send. Okay. We've talked a little RV. We've talked a little LV. Here's another trick I've got up my sleeve for you. 64-year-old patient is going to present to the ED with respiratory failure due to a multifocal pneumonia. They were hospitalized a few weeks ago for COVID pneumonia. They had oxygen requirement. Seemingly, they got better. Now they've come back with mucopurulent cough. They've got fever chills, new consolidated opacities. Their workup has been negative for COVID ×2. They had 2 PCRs, both negative. But they've got sputum and they've got blood. Both are positive for Pseudomonas aeruginosa. They've been now intubated and mechanically ventilated for their respiratory failure, treated with appropriate antibiotics. And they actually had some vasopressor support right out the gate for septic shock in the setting of their bacteremia and their bacterial pneumonia. So they've had some surveillance cultures that have cleared. Their procalcitonin was initially sky high. It's fallen. So really things kind of looked like they were getting better. They had this initial high pressure requirement, which then kind of dropped off. But now it's climbing again. So just to sort of like clarify things a little bit, here we're on ICU day 4. Days 2 and day 3, they had this sort of present but markedly improved pressure requirement. But now they're uptrending again, as is their serum lactate. Fever curve off antipyretics has been reassuring. I know that's a lot of info for you, for our audience, Nick. So let me stop there, get your thoughts, and see, hey, what do you think's going on, and what else do we need to sort this out?
All right. So septic shock due to Pseudomonas aeruginosa pneumonia. They were getting better. Now they're getting worse. And so normally I would expect somebody on day 4, who was doing better on day 2 and 3 to be doing even better. Right. But that's not what we're seeing. So this is alarm bells time. It's very easy to sort of normalize the abnormal, but we got to be careful not to do that. Right. We need to have a broad differential here. It's very easy to sort of be like, oh, they're just septic again. But, that's not really what the data shows. You mentioned a lot of things, right? The fever curve is better. Their procal is better. The lactate is better. Like this is not, or you said the lactate is trending up actually. So this is looking like shock, but maybe not septic shock. So we got to think about our fundamentals. Maybe make sure that there isn't a new abscess, a new pleural effusion, some undrained source of infection or some other infection. Make sure there isn't some new like infection in the abdomen or something else, some other complication. And one of the things we need to think about, as part of this is the heart, right? Remembering that, people like this are set up for things. He's older, he's got, severe critical illness. He could easily have like a septic cardiomyopathy. So I think, while we're thinking about the logistics of getting that head-to-toe CT scan, we probably need to also get out the ultrasound and take a look ourselves, maybe with special attention on the heart, given the topic of today's episode.
Indeed. Yes, I could agree more.
That's good. That's good problem solving. Answer the question. You know what the topic is. Yeah.
Yeah. Yes. Fair. Yeah. No. A little bit of a little advantage there. So, okay. So we're gonna grab our ultrasound. We're gonna take a look. We don't see anything off the bat to suggest a bleed or an obvious fluid collection. Of course, your ultrasound is a little bit limited in some respects, but nothing obvious. So
Okay.
we're going to go ahead and call down to CT to arrange for some cross-sectional imaging. But then as we're acquiring our cardiac views, it does become clear that we've got some LV and RV hypokinesis. We've got an LVOT BTI that's about 10 to 11 centimeters and a TAPC of 1.3 centimeters.
Okay. So those are worrisome numbers. That's a low LV outflow tract VTI. That's not a TAPSI I want to see either. So this is concerning for like a biventricular failure picture, especially in somebody who's kind of remanifesting shock. There are a couple of different types to consider here. There's like Takotsubo cardiomyopathy, which is sort of an apical ballooning picture, which is related to stress. There are some other types of stress cardiomyopathy as well. I'm not going to go into all that now. We can have a whole episode on that. But I think one of the things that we need to do is we need to sort of confirm this diagnosis. So getting better echocardiographic images by a formal echo would probably be helpful.
I agree. Yeah, I think that's spot on. I think we can hem and haw about which theoretical pathophysiological construct is really at play here. But I think the focus is really confirming the diagnosis as far as does this person truly have depressed cardiac function, depressed biventricular function? So getting a formal echocardiogram, I think, is great. So yeah, we'll go ahead and get our echocardiogram done as you recommended. And we'll say that the technologist comes in, they do the sonogram, confirms what we saw on our bedside assessment.
5E failure.
Yep. What else do we want now?
This is probably a patient where a SWAN could be helpful. We're probably going to be titrating quite a few different therapies, and that could help us out. There doesn't seem to be any major contraindications or risks to it either. So this is a pretty straightforward situation to put one in. A couple other things that we should probably think about as well. Adrenal insufficiency comes to mind too. Hypothyroidism comes to mind. Like whenever somebody is sort of shocky a couple days in, sometimes I also worry about people who were on meds that got held, especially like in a 64-year-old patient. Sometimes like this person was supposed to be getting levothyroxine and they didn't have oral access, and now they're on day 4 and their levels are low. So just going back to sort of the admit note, kind of looking things over, making sure that we haven't made any errors that are also contributing probably makes sense. But I think we have the answer here. There just may be something else that's also driving it.
Absolutely, yes. I think that's important. I think it's you don't want to cut out the rest of the workup that you thought of because multiple things can coexist. For one thing.
Yeah, and there's a phenomenon called satisfaction of search, right? Where
right.
you see the bullet on the X-ray, and now you stop looking for all the other things that are also injuries. Same thing
Absolutely.
here. It's easy to sort of find one organ system problem and miss others. So we just got to remain vigilant.
Perfect. Yeah. So we're going to go ahead and we're still going to get that CT of the chest, abdomen, pelvis with contrast. Doesn't really suggest that you missed an abscess or a bleed, which is great. Your pulmonary artery catheter goes in. You calculate a CPO of 0.50 and a PAPi of 0.78 with an RA pressure of 16 and a pulmonary capillary wedge pressure of 20.
Okay, so all bad news. Remembering
Right.
that a cardiac power output of less than 0.6 watts is low. This is low. Remembering that a PAPi of less than 0.9 is low. This is 0.78. You said his right atrial pressure is also high at 16. His wedge is high at 20. So basically, a picture that strongly suggests left and right or biventricular failure.
Yes. So okay, pretty convinced of the diagnosis. Having said that, let's focus on management. What are we going to do
Okay.
here? How are we going to approach this?
So I haven't read the literature on this as recently as you have. There's probably more than 5 articles on PubMed,
Yes.
but there's still probably a relative dearth. There aren't
Mhm.
big RCTs of septic cardiomyopathy.
There
These
are not.
patients are often excluded from the RCTs that we have. So I think we need to just start off by acknowledging that we're in kind of a limited evidence zone here, and as such, we should sort of do fundamentals really well. So Okay. Well, first off, it sounds like we're treating the underlying infection well, but we want to make sure, we haven't narrowed it appropriately. We've got our sensitivities back. We're covering. That's all important. Fluid resuscitation is tricky in these cases, right? Because on one hand, people who are septic are often also hypovolemic. They have high insensible losses, so they often need fluid. This guy's on hospital day 4. It's pretty unusual for somebody to be hypovolemic this far into critical illness. He's been getting IV meds for days and other stuff. So my suspicion is he probably doesn't need a lot of volume, and I think we got to be cautious. I think the LV and the RV are both telling us that they have high filling pressures with that right atrial pressure and that wedge pressure. So I'm probably not going to lean too much on fluid in this guy, despite the fact that the underlying diagnosis is, quote, sepsis. The thing to avoid would be like, oh, pressures are going up, just give a liter. Oh, pressures are still going up, give another liter. And then before you know it, this person's gotten like several liters of crystalloid they didn't need and are actually harmful. So let's not do that. From a vasopressor perspective, as we often say, like norepi is not, it's never really the wrong choice, but I think we got to be careful here because sometimes it actually can make things worse. If this is somebody who's like shot up to, a max dose of norepi, I'm really worried that may be making things worse, that's increasing the afterload that this struggling left ventricle has to pump against. So I think this may be a situation where I kind of want to add an inotrope and see what happens. Dobutamine would be a good choice here. I probably don't want to do too much afterload reduction until I kind of know how they tolerate that. And then lastly, mechanical circulatory support, case reports of different things in cases like this. We've definitely done them at my institution. They can be very effective. I think before I get too into that, we should probably see how he responds to fundamentals.
Yeah, I think that's all very reasonable. I think the further you get down on that list of interventions, the more and more fringy you get as far as like the data supporting the intervention. So specifically mechanical circulatory support in these patients, it's like essentially all based on case reports and case series and like for example, intra-aortic balloon pumps are an option. It doesn't make great pathophysiologic sense other than to support coronary artery perfusion pressures in a failing heart. But, we're still not dealing with like a primary coronary insult. So it's like, yeah, you could try it, but it's maybe just as good as some of these other interventions that have also been studied in case reports. So it's like, well, which one do you choose? Who knows? Like,
we're far away from the danger shock trial here.
Oh
I think one other thing to remember too is that like this guy was bacteremic just days ago. It sounds like, so I'm not super excited about putting extra plastic into his body if I can avoid it.
Absolutely.
And so I think this is a situation where we have lots of less invasive therapies we can try first.
Totally agree.
All right. That was fun. Should we do another one? I've got one for you.
Awesome.
All right. So this is a case that I've seen several times. I still occasionally have nightmares about it. Obviously, this is not a real case. This is inspired by actual events. This is like Law and Order. They say that, right? So you're working in the medical ICU. You get a phone call from an outside hospital ED about a 65-year-old man with right upper quadrant pain, hypotension. They're concerned for sepsis with a biliary source. There's some labs that kind of support this picture. He's got an INR of 2.2, direct bili of 6, creatinine 1.3. There's some odd features, though, that you kind of flag mentally as you're hearing the case. So his white count is 7 with a normalish diff. His procalcitonin is negative. They got a right upper quadrant ultrasound in the ED, and it shows borderline common bile duct dilation, borderline gallbladder wall thickening. The ED does all the right things. They start him on antibiotics, vasopressors, and then they say, hey, we got to transfer him to a higher level of care facility. Do you accept him in your ICU? The gastroenterologists say they want to do an ERCP. So as you're waiting for him, or, I guess he rolls in and he's not quite what you expected. He apparently en route, he became hypotensive. They had to crank the pressors way up. He became unresponsive and they had to intubate him. So you see him, he's on max dose norepi. He's afebrile. His heart rate is 130. Blood pressure is 75 over 60. Sats are 90 on 100% FiO2 by the ventilator. He's anuric. I mean, things are not looking awesome. You feel his pulse and it's weak, his skin is cold, his cap refill's prolonged. You listen, you hear crackles bilaterally. He's sedated, but when you press on his belly, he's kind of diffusely tender. Um, so I gave you a lot of information there. What's your kind of gestalt on this guy? What do you want to do first? What else do you want to know?
Great case. So there are a lot of elements of the story that make me think of biliary sepsis. And then you start to kind of take the blinders off and pay closer attention to the objective data. And you recognize the fact that you've got a narrow pulse pressure, which is pretty unusual for septic shock. You've got someone who's not responded to 30 mics of Levophed. And you've also got some values that, I mean, a leukocyte, you don't have a leukocytosis. You have for all intents and purposes, a normal white blood cell count. And you've got borderline abnormal imaging, which frankly could be explained by any number of pathologies that are not biliary sepsis.
Yeah, I think sometimes when we're grasping at a diagnosis and something is read out as like upper limit of normal,
Right.
we kind of forget the word normal in there, right?
Right. So, I'm not sold. It's like initially it would be very easy to just be like, oh yeah, cool. This is cholangitis and start treating as such, which I think is what happened initially. But there are so many things here that the moment you sort of, again, take those blinders off, you realize, yes, this is shock, but I don't think this is sepsis. Again, that tachycardia, but the narrow pulse pressure, recognizing that pulse pressure is proportional to stroke volume. So I'll be honest with you, Nick, I think this could be cardiogenic.
Great. Yeah, I think you're demonstrating a really high level skill of like advanced clinicians, which is the ability to sort of see what's not there and see the thing that doesn't fit. It's easy, especially when you're hearing about a patient that you haven't seen, to sort of accept the narrative that you're told. And it takes a little bit more cognitive load to say, wait a second, something about this story doesn't seem right. This value seems completely at odds with this other stuff you're telling me. So I think you've correctly inferred that this is probably a heart problem. How could you confirm that hypothesis at the bedside? What are some tests you could do right off the bat?
Yeah. Okay. So I think both of us are big fans of point of care ultrasound. So, I mean, I think that's probably the easiest thing to do when you're dealing with, how shall I say, partially differentiated shock. I mean, at this point, I think I'm leaning more towards cardiogenic.
Yep.
Maybe, who knows? Maybe this is by hypovolemic, and this is just someone who hasn't been, taking a lot of PO and has had a lot of diarrhea that I haven't heard about. So I would say I'm still calling this undifferentiated shock favoring cardiogenic, actually maybe less likely septic. And so for that reason and that reason alone, I'm grabbing that ultrasound, taking a look.
Okay, so you see a very large right ventricle, a low TAPC, signs of increased right atrial pressure. Specifically, you see reversal of flow when you put Doppler on the IVC. Unfortunately, not getting awesome windows for VTI.
Okay, so now I'm thinking a lot less likely that this is a hypovolemic case, because it would make sense to have a large RV. And now I'm thinking more, even more cardiogenic, and frankly, I'm thinking more like maybe right-sided failure. Frankly, maybe right-sided heart failure. And so, in this particular case, I'd like to have some real numbers, some objective numbers, and so I think a SWAN would be very helpful.
All right, you float your SWAN. You get a PA systolic of 45, a PA diastolic of 30, a right atrial pressure of 20, and a cardiac index of 2.0 liters.
Okay, great. So that cardiac index is not great, but it's could be worse. But I'll take it for now. But I'm actually kind of more concerned with some of the other values, if I'm being honest. So if we do the math, we can calculate that PAPi. So we're going to take that PA systolic minus PA diastolic divided by the RA mean, or the RAP. So in this case, that's going to be 45 minus 30 divided by 20. That's going to give you 0.75. And so
it's almost like I chose those numbers to make that easy for you.
Yes, thank you. So recall that a PAPi less than 0.9 is bad. Of course, 0.75 is less than 0.9, so that's not great.
So that's bad.
Yeah, that's bad. And then I think we have what we need to calculate a CPO here as well, which I think would be kind of right on the nose. Yeah, I think it's like 0.65 if you were to calculate it out.
Yep. So not awesome.
Not awesome. Yeah. So like again,
but right worse than left in terms of numbers.
Yeah, and that's kind of like sort of based on your cardiac index is kind of what I was thinking anyway. So
okay. So what do you want to do for this guy?
Yeah. So tough case as well in this gentleman. So you've got someone who's already pretty tachycardic. So from an I think we're going to want to provide some inotropic support, and this is someone again who maybe I would lean a little more towards milrinone, and see how he tolerates that. You may very well find yourself needing some vasopressor support to support the MAP. This is a case where vasopressin, potentially angiotensin 2, possibly even something like a little phenylephrine might be helpful to support that afterload. Again, you got to be really careful here because that it's not like our cardiac index and our CPO is just like super reassuring. So it's tough. It's once again that Goldilocks principle of trying to be just right and like tinker with the values just perfectly. Helpful again to have that swan in place. So fortunately we have that. I probably would like to use vasopressin preferentially, again, because of that potential for PA pressure reduction. Same reason why I would like to use something like inhaled epoprostenol or nitric oxide. Also gives you that PVR reduction. Same reason
and recall that he's hypoxemic, right? His SATs were like 90
exactly.
100%.
So same reason why I would want to avoid hypoxemia. So be pretty aggressive with my oxygenation, make sure that I'm hitting my SAT goals, etc. With RV failure, it's like some folks need volume. This is probably someone who doesn't need volume. They're already showing signs of congestion. I think volume would possibly be a death knell in a person like this. So I would give them diuretics to try to treat that congestion. And then in addition to managing their hypoxemia with FiO2, I think careful use of PEEP can be helpful to support that oxygenation. But again, remember that, from our discussion earlier, positive pressure when you're dealing with predominantly right-sided failure can be a double-edged sword. We want to support oxygenation, but we don't want to overwhelm the RV and reduce your preload. So you just have to be very, very careful there.
Excellent. Okay. All great things. Inotropes, pressors, inhaled pulmonary vasodilator, plus minus diuresis, careful use of PEEP. All right. You do all those things and things get a little bit better. His index is like 2.1, still anuric, more hypoxemic. SATs are in the 80s, despite 100% FiO2 and a PEEP of 14.
Okay. Yeah. So kind of spinning our wheels for the most part here. So you've got someone who's been maxed out on medical therapy. This is really a time where if we haven't already engaged our shock team, which frankly we probably should have at this point, we definitely want to make sure that multidisciplinary discussion is being had, because we're talking mechanical circulatory support at this point in time. We've kind of like done everything we can do medically. And this is really the time when we'd want to add something else to try to save this person's life.
Excellent. So you the you assemble the fellowship, CG Shock team, meets on the phone. You share the case. Various options are weighed. Something for right-sided support is obviously essential. The question is what. In this case, it's actually an easy decision because he's so hypoxemic. It really pushes you towards VA ECMO, right? Because you probably want the oxygenation support and the flow support. So the decision is made to do that.
Yeah. Okay. Awesome. Yeah. So, that's definitely something that I think is nuanced, and it's interesting. 65-year-old male. That's aggressive in some cases because you have to think of their comorbidities and all of that, and so. good plug for having that that shock team, and I certainly wouldn't want to have to make that decision in a vacuum. And furthermore, I think probably saving the nuances of like cannula positioning and decision and all that for that ECMO talk we're going to have later is going to be good for our audience at this point.
Yeah. So great job. Yeah, you nailed that case. I, as I mentioned at the beginning, like this is a case that I see every now and then, and I think we should maybe double click on the physiology or pathophysiology just a touch, which is to say that right-sided failure can cause congestive hepatopathy, and it can sort of mimic a liver pathology, right? And I think this is kind of a thing that's easy to miss. It's easy to sort of like have tunnel vision on that right upper quadrant pain, elevated Billy, elevated INR, and sort of miss the forest for the trees, And so in remembering that RV failure can cause liver failure is really important. I think if our listeners take one thing away from this case, it's that. I think you did a great job kind of assessing RV failure, adding therapies, and I think this is an important one to remember because it's an easy diagnostic mistake to make initially when you have less information. All right, so we covered a lot today. You wanna close us out, man?
Oh man, yeah. Massive episode, tons and tons of content. Hopefully, our audience is still breathing.
To the people who are watching us on YouTube, you can actually
Yeah.
see that we've had like 3 costume changes.
Yes.
Not because we're vain, but because we've recorded this over like 3 sessions.
Yes, 3 subsequent days of recording to get this to the masses.
It's a marathon, Iron Man
yes.
of episodes.
That's right. So yeah, we covered a lot over these 3 days. We started with our discussion of what is cardiogenic shock. We talked about some of the reasons why y'all should care. Tried to put together a pragmatic definition for you all. We talked about how it's diagnosed. We talked about sort of like the SCAI criteria for staging, but also how you can sort of clinically diagnose it at the bedside using your exam. We talked about also some of the tools you have available to sort of assess a patient in cardiogenic shock, whether it be POCUS, the pulmonary artery catheter, et cetera, to kind of both make that diagnosis, but more importantly, follow that patient through the course of their illness. Essentially, talked about what's in the toolbox and how best to use it both at time of diagnosis, but then during the course of that patient's disease. We talked quite a bit about our treatment options, right? We talked about our inotropes, our vasopressors, diuretics, and then we went even further and talked about those mechanical circulatory supports options, talked a bunch about those in the context of our cases. And we've got a lot more to talk about. Like Nick and I said, we've got plans for that ECMO episode that's coming up, and then other episodes on mechanical circulatory support, focused episodes on LV failure, RV failure, et cetera. So tons in the woodworks. Stay tuned for more.
Yeah, we went deep, but we also only scratched the surface. So get excited for what's to come.
All right, folks. Well, hopefully you guys enjoyed our very long and I think jam-packed episode on cardiogenic shock, kind of intro to cardiogenic shock. Hope you guys had fun. Even though it was a lengthy one for us, I really had a ton of fun working with you, Nick, on this one.
Me too, man. This was fun.
I learned a ton myself, and I think our audience probably did too. As always, guys, if you all want to learn more, you should definitely check out our website for our new toolbox that Nick has been working on, and we look forward to that growing. Also, of course, show notes, infographics, all that good stuff. Website for you guys is www.criticalcaretime.com. While you're there, subscribe to our mailing list, leave a comment, go to our store, all that good stuff.
Yeah, definitely buy some swag while you're there. You can check out our infographics, check out our calculators, and buy some cool stuff like what I'm wearing right now. All right. Well, we've come to the part of the show where we like to say thanks. Thanks to everybody who has listened to the show, left us reviews, comments, supported us. We really appreciate all your kind words. We listen to them. They inspire us to do episodes. And so thank you all. If you haven't yet given us feedback and you enjoyed the show, please give us a 5-star review on your favorite podcast app. It helps other people find us. And we love the feedback we get from you. We're on Blue Sky now at criticalcaretime.bsky.social, individually at Nick Mark or at Askin for Air. Nice. You can also tweet at us, follow us on Instagram, Threads, and check out our YouTube channel.
That's right. And we'd like to say a big thanks to our sponsor, C-Star Medical. We're fortunate and grateful that this episode and all episodes of Season 2 of Critical Care Time are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
And before we go, we'd like to say a big thanks to the incredible members of our team who make this possible. Our production folks over at Podpace do a great job of editing us and making us sound smarter than we are. We'd also like to thank Kurt Belknap for the awesome theme music you're hearing now.
And disclaimer time, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients and encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thanks again for listening. I am Dr. Cyrus Askin.
And I'm Dr. Nick Mark. Thank you all. See you next time.